Hello, I'm Manoj Karmakar. I welcome you to the 7th edition of the ISSPS webinar series today, the 38th of October, 2021. I bring you a warm welcome from the city of Hong Kong, and I hope you are healthy and well wherever you are. If you are joining us for the first time, I extend a very warm welcome, as I have alluded to. If you are joining us for the 7th time, then I really commend you for the faith you have placed in our organization. And hopefully this will be another event where I can promise you, you will not be disappointed. Okay, today, despite the pandemic, Hong Kong is still bustling. Unfortunately, our international borders are still shut. But nevertheless, I bring you greetings from this beautiful city that has been my home for nearly 27 years now. I'm coming to you live from the studios in Prince of Wales Hospital in the New Territories of Hong Kong. We are part of the Chinese University. This event is being organized by the Department of Anesthesia and Intensive Care, the Faculty of Medicine, and is being one of the events for the 40th anniversary celebration of the Chinese University. As I mentioned before, this also happens to be the 10th edition of our ISSPS since our beginning in 2009. So we've also come a long way in education for spine and paravertebral sonography. This event is being supported by VII. VII is one of the up-and-coming providers in ultrasound equipment. They are showcasing the Labat system during this series. We will be using that during the live demonstration today. They have a variety of different equipments, and they have been quite innovative in terms of incorporating artificial intelligence, needle guidance, and various other educational portals within the ultrasonography device. So if you are looking out for this ultrasound system, the Labat system, then reach out to your nearest VII agent, and I'm sure they will be more than willing to help you. So far, we have about 3,150 participants from all across the globe. We are reaching out to about 93 countries. Majority are from Asia and the Oceania, Australia and New Zealand. But we also have many of you who are logging in from far away in South America, Ecuador, Peru, Colombia, etc. And I welcome you all to this event. So I think this is a reward of this pandemic. We can reach out to so many of you with just the click of a button. So today's event, I will be joined in by Dr. Ke-Vin Chang from Taiwan. We have a really packed session for you today. We made some changes to the schedule, but you will probably not realize it. The only thing is because there will be some repetition in certain aspects of costoclavicular, lateral sagittal, infraclavicular, etc. So we've decided to take away one of the lectures and use that time to sort of later on in the live demonstration. Okay, so Dr. Ke-Vin Chang will be joining me. He's a clinical associate professor at the Department of Physical Medicine and Rehabilitation from the National Taiwan University Hospital. He's also belongs to the faculty from the Department of Medicine and Rehabilitation in the National Taiwan University in Taipei, Taiwan. Don't be fooled by his youngish look, because he is truly a giant in his field of musculoskeletal medicine. He's a very prolific publisher. He's I can describe him as an innovator in the field of musculoskeletal medicine, and he has developed many new methods of imaging small nerves. And this is going to be his goal today, to demonstrate to us how you can image some of the smaller nerves. And I can bet you'll not be disappointed with what Ke-Vin has to offer you today. Just a couple of housekeeping matters. This is a webinar format, so you will have limited privileges. But however, we have a question and answer session. There will be 2 question and answer sessions. The first one will be after all the lectures are over. So there'll be about 4 lectures, and then we have a Q&A. We have one of my colleagues, Dr. Rossini Wong, who will be in the background. She's one of my consultant colleagues. She will be moderating the questions. So please use the chat function to ask your questions to the speakers. But don't forget to mention where you come from, or where you are posing the question from, your country or your place of residence. The questions will be decided by the moderator. So in case your question doesn't get picked up, we'll try and answer them through the chat as we go along during this session. Now, the next webinar, number 8, is going to be held on the 13th of November. It is truly a giant session. So I would advise you mark this in your calendar, because this is a very hot topic about thoracic blocks, particularly thoracic epidural, thoracic paravertebral, and the new kid on the block, erector spinae plane. And some of the giants in this field will be joining me to discuss some of the more controversial aspects of this, from anatomy all the way to its application in clinical practice. So don't miss this event. These are some of the books that we put out from our stables in Hong Kong. So if you are interested in musculoskeletal sonography, sonoanatomy, these are worthwhile considering, and some of the details of how you could get hold of them that at the best prices that money can buy, you can find them in our website. So without further ado, we're going to start off with my talk on sequential ultrasound imaging of the brachial plexus. This will set the stage, hopefully, for some of the later presentations about how we perform some of the more novel blocks of the upper extremity. Hello, I'm Manoj Karmakar. I bring you greetings from Hong Kong. I'd like to take this opportunity to thank the organizers for inviting me to speak at this meeting. Also, before I begin, I'd like to declare that I have no conflict of interest whatsoever relating to my presentation. The objective of my talk is to describe a sequential ultrasound imaging technique that goes by the acronym SUIT that would facilitate accurate identification of the individual elements of the brachial plexus before the performance of a brachial plexus block, and discuss some of the potential advantages of using a sequential ultrasound imaging technique. The brachial plexus is made up of the roots, trunks, division, and the cords. There are 5 roots that make up the brachial plexus, which are from C5, 6, 7, 8, and T1. You can see here, they are the C5, 6, 7, 8, and T1. These are the ventral rami of the cervical nerve roots. So when we say roots, these are the ventral ramus of the brachial plexus, and they are not the cervical nerve roots. They are indeed the ventral ramus of the cervical nerve roots. The ventral ramus of C5 and 6 join to form the superior trunk. The C7 ventral ramus continues as the middle trunk, and the C8 and T1 fuse to form the inferior trunk. The three trunks then divide into an anterior and a posterior divisions, which then come together to form the three chords of the brachial plexus. Since we are discussing above the clavicle, we're going to restrict ourselves to identification of the individual ventral rami, the individual trunks, and maybe some of the divisions of the superior, middle, and the middle trunk. The use of ultrasound for brachial plexus blockade was first described by Stephen Capral in 1994. It's about 27 years ago. They used 2D ultrasound for supraclavicular brachial plexus block. Brachial plexus sonography literature in the radiology literature only appeared in 1998, 4 years later. When you perform an interscalene brachial plexus block, you identify the C5 and 6 ventral rami, and the local anesthetic is injected close to the ventral roots of the brachial plexus, i.e. the C5 and 6 ventral rami. During a supraclavicular brachial plexus block, you identify the trunks and divisions of the brachial plexus of the supraclavicular fossa. During an infraclavicular brachial plexus block, you target the chords of the brachial plexus below the clavicle, and there are different approaches to this. And during an axillary block, brachial plexus block, you target the terminal branches of the brachial plexus at the axilla. So during an interscalene brachial plexus block, a transverse oblique ultrasound scan is performed at the neck, where you identify the elements of the brachial plexus between the scalenus anterior and the scalenus medius in the interscalene groove. These elements within the brachial plexus are the roots of the brachial plexus and have often been likened to the stoplight sign, where the three lights resemble or represent the ventral ramus of C5, 6, and 7. The needle is inserted in plane from a lateral to medial direction through the scalenus medius muscle so that it's in a periplexus location where the local anesthetic is injected and then used for shoulder surgery. But the question is, how accurate are we in identifying the individual elements of the brachial plexus that we are often forming our local anesthetic injections? Let's take a look at the literature. Stephen Capral, indeed, in 1994, in this classic publication, documents that he was able to demonstrate the C5 to T1. That means all the ventral ramus of the brachial plexus was seen in a single interscalene groove image in 1994. Jose Andres and Xavi Salablanche reported that the elements within the interscalene groove are indeed the trunks of the brachial plexus. They are not the roots of the brachial plexus. More recently, Dr. Perles and Dr. Chang and a group from Toronto have labeled this more conservatively and more cautiously as probably the roots and probably the trunks or divisions of the brachial plexus at the interscalene and supraclavicular fossa respectively. Peter Marhofer and William Harrop Griffith and their colleagues labeled the C5, 6, and 7 within a single transverse oblique scan of in the interscalene groove and labeled them as nerve roots. There are also several editorials that have been published that highlight the inaccuracies in labeling of the various brachial plexus elements within the anesthesiology literature. They've often described that there is a need to reevaluate the stoplight sign because they are not always the C5, 6, and 7 ventral ramus. It is with this objective that Dr. Carlo Franco and Dr. Williams performed this cadaver study in which they investigated, or they performed cadaver dissections to evaluate what really made up the three lights of the stoplight. In their cadaver dissection, they consistently found that the C5 root was significantly smaller than the C6 and 7. They also found that C6 and C7 ventral rami often presented macroscopic evidence of intra-root splitting. What does it mean? As you can see here in this very clear-cut dissection by Dr. Franco and his colleagues, you can see here C5 ventral ramus is the smallest of the 5 ventral rami of the brachial plexus. He also demonstrated that the C6 and C6 often exhibits features of intra-root splitting. That means the C6 and C7 will often exhibit features of intra-root splitting, like you see in these images here. So therefore, they go on to conclude that the stoplight sign actually has 3 lights, but actually they are only made up of 2 nerves. This has clinical significance because if you misidentify the 2 elements of the C6 as C6 and 7, and you place your needle between the 2 elements of the C6, that would amount to an intraneural injection and may result in devastating neurological sequelae postoperatively. Therefore, it's desirable for safety and accuracy to accurately identify the individual elements of the brachial plexus during a brachial plexus block. When you perform brachial plexus sonography, there are a number of key anatomical landmarks, i.e. anatomical landmarks that have very typical sonomorphological features. One of them is the C7 transverse process. As you can see here, the C7 transverse process has only a single posterior tubercle. The anterior tubercle is either rudimentary or is missing. The C6, which is the contiguous transverse process above the C7, has a very prominent anterior tubercle. This is also referred to as the Chesniak's tubercle. So once you identify the C7 transverse process, it's easy to identify, then locate the C7 ventral ramus and the C6 ventral ramus contiguous to that. Also, another anatomical landmark in the brachial plexus highway is the spar of the brachial plexus that was described by Dr. Hanna, a neurosurgeon. Traditionally, when you look at the anatomy of the brachial plexus, it's often described that the superior trunk divides into a suprascapular nerve and then gives off an anterior and a posterior division. However, in this trifurcation is where Dr. Hanna, in his cadaver dissections, demonstrated that the anatomical arrangement was not an SAP arrangement. In fact, he single-handedly performed this cadaver dissection and challenged what was described in the early 1400s by Vesalius. He challenged this anatomical dictum, saying that the arrangement is not SAP, it's usually in the form of a suprascapular nerve, followed by the posterior division of the superior trunk, and then the anterior division of the superior trunk. So Hanna goes on to describe this as the spar of the brachial plexus. More recent publications on the brachial plexus actually represent it as the suprascapular nerve from a lateral to medial direction, followed by the posterior and then the anterior division of the superior trunk. So this is what is often referred to as the spar of the brachial plexus. Also, another important neural arrangement in this brachial plexus highway is the neural stack formed by the superior trunk, the middle trunk, and the C8 between the 2 scalene muscles and overlying the transverse process of T1 and the first rib complex. As you can see here, the C5 and 6 have fused to form the superior trunk, and the C7 continues as the middle trunk, and the C8 is now lying on top of the T1 transverse process and first rib complex. So this neural stack that you see is very consistent from individual to individual. So what lessons have we learned so far with brachial plexus sonography? We've learned that the C5 is the smallest of the three roots between C5, 6, and 7. The C6 and C7 exhibit intra-root splitting, which is usually macroscopic but can also be identified using ultrasound. The stoplight sign that's often used in the brachial plexus sonography literature in regional anesthesia are actually made up of only two nerves. The C7 and C6 transverse process exhibit unique sonomorphological features. The spar of the brachial plexus is where the trifurcation of the superior trunk occurs, and the arrangement of the suprascapular nerve posterior anterior division are very consistently identified in most individuals. The C8 ventral ramus lies on top of the T1 transverse process and the rib complex that I demonstrated to you. The T1 ventral ramus and the C8 are more difficult to visualize, particularly the inferior trunk is more difficult to visualize, but nevertheless, with the technique that I will be demonstrating to you, you'll hopefully be able to identify this in about 40% of individuals. So what is the sequential ultrasound imaging technique? The sequential ultrasound imaging technique goes by the acronym SUIT, S-U-I-T. It's a transverse oblique scan sequence that we start from the supraclavicular fossa, and then we progressively sweep the transducer in a cephalad direction through 7 contiguous sites, and during this process you are able to identify the individual elements of the brachial plexus. Starting from the supraclavicular fossa, you then sweep it to identify the C7 transverse process and the C7 ventral ramus, thereafter the contiguous C6 transverse process and C6 ventral ramus, and then the C5. And once you've identified the C5, the transducer is now manipulated or translated in a caudal direction to see the fusion of the C5 and C6 to form the upper trunk. It's also often referred to as the Erb's point, where the C5 and 6 fuse to form the upper trunk. And as I alluded to before, the neural stack formed by the superior, middle, and the C8 nerve ventral ramus on top of the T1 transverse process and first rib complex, and thereafter identify the formation of the inferior trunk at the supraclavicular fossa. So the transverse oblique scan starts from the supraclavicular fossa. You can see here we're using a high frequency linear transducer that is gradually swept in a sweeping motion from the supraclavicular fossa all the way up to the C5 ventral ramus transverse process, and then it's swept back again in a caudal direction with a gradually increasing angle until you get back again once to the supraclavicular fossa. During this sweeping motion, at the supraclavicular fossa, you can identify the trunks and divisions of the brachial plexus as they are located posterior and lateral to the subclavian artery, and often deep to the omohyoid muscle, as you can see here. Next, when you sweep the transducer further cephalad, one can identify the C7 transverse process by its very typical sonomorphology of having a single prominent posterior tubercle. You can see here this is even more prominent. You can see here the C7 transverse posterior tubercle, and anterior to that lies the C7 ventral ramus. And thereby you can see the ventral ramus that's in the interscalene groove between the scalenus anterior and medius. Cephalad to that is the C6 ventral ramus. So the C7 ventral ramus is located anterior to the C7 transverse process, and adjacent to that is the vertebral artery and the vertebral vein in that exposed area. So therefore, everything that looks hypoechoic or anechoic and round to oval next to the C7 transverse process is not a nerve. You have the vertebral artery and the vertebral veins that are located next to it. If you sweep the transducer further cephalad from the C7, you can now identify the C6 transverse process by its very prominent anterior tubercle, the Chesniak's tubercle, and a much smaller posterior tubercle. In between lies the C6 ventral ramus as it emerges from the intervertebral foramina. Careful add to that, in the interscalene groove is the much smaller C5 ventral ramus. As you can see here in this video loop, the C6 is a very prominent anterior tubercle. The posterior tubercle is much smaller. The C6 ventral ramus is lying in between the two tubercles, and the careful add to that is the much smaller C5 ventral ramus. So the C5 ventral ramus is a much smaller nerve when compared to the C6 and C7. Also, you can see here the typical sonomorphology of the C7 and the C6. The C5 ventral ramus is a much smaller nerve, and as it emerges from the intervertebral foramina, it can be clearly identified between the two tubercles. As you can see in this video loop, it's just emerging from the intervertebral foramina, and it lies between the anterior and the posterior tubercles of the C5 transverse process, a much smaller nerve. Once you've identified the C7, if you sweep the transducer careful add, you can see the C6, very prominent anterior tubercle, and a much smaller C5. I think it's also important to understand that these ventral ramus may exhibit splitting of these nerves, as been referred to in the literature, and I had alluded to previously in one of the cadaver studies by Dr. Franco. So when you scan these nerves in the interscalene groove and you dynamically scan them proximally and distally, you can see here that this is indeed the C6 ventral ramus that is now exhibiting intra-root splitting. So you can see there are three, but actually this is C5 and the two components of the C6 ventral ramus. This is another image where you can see the C5 and C6 and C7. You can see the C7 is now splitting into two parts here. They are the two parts of the ventral ramus of the C7. In fact, in this individual, you can see this is the C7, which shows splitting. The C6 also exhibits splitting, and the C5 is a much smaller nerve. So you can see here that there is actually 5 neural elements: the C5, C6, C6, C7, and C7. So it can be very easily misinterpreted as C5, 6, 7, 8, and T1. Once you have identified the C5 transverse process and the C5 nerve root ventral ramus, it is now important to focus your attention on what the C5 ventral ramus does in terms of how it fuses with the C6 to form the superior trunk. And therefore you see this superior trunk sequence in this video. You can see here, you see the C7 here. Now you see the C5 and C6. The C5 and C6 used to form the superior trunk, which is more clearly visual here. You can see the C5 and C6 fused to form the superior trunk. The middle trunk is continues as the C7. And if you focus your attention now only on the superior trunk, you will see it forms 3 divisions here. You have the suprascapular nerve, the posterior division, and the anterior division. So this essentially forms the spar of the brachial plexus. So you have a suprascapular nerve, the posterior division, and the anterior division. And just caudal to that is the middle trunk, and the C8, which is now lying on top of the apex of the lung here. It's also important to draw attention that the transverse cervical artery is very closely related to the superior trunk. It often crosses the interscalene groove anteriorly, lying on top of the scalenus anterior and the medius muscle. On certain occasion, it may also intersect it may go through the scalenus, the interscalene groove between the superior trunk and the middle trunk. Next is, after you've identified the superior trunk, then it's time to identify the middle trunk and the C8 ventral ramus neural stack. So this neural stack is very clearly identified because the C8 lies on top of the T1 transverse process and the first rib complex. So once you can see here that the superior trunk is a much larger nerve, you can see here, the middle trunk lies just caudal to the superior trunk, and the C8 is the isolated nerve, ventral ramus, here on top of the T1 transverse process and the first rib complex. Once you have identified the neural stack formed by the superior trunk, the middle trunk, and the C8 ventral ramus, we now will try and identify the formation of the inferior trunk, i.e. the fusion of the C8 with the T1. As we know, the C8 ventral ramus lies on top of the T1 transverse process and the first rib complex. It fuses with the T1 that comes from underneath the first rib and fuses with the C8 ventral ramus on top of the first rib further down. So when you perform a scan, as I showed you the neural stack, you are visualizing the superior trunk, the middle trunk, and the C8 on top of this bony complex. This is also seen very clearly in this cadaver dissection by Dr. Zhu and his colleagues. You can see here the C8 is lying on top of the bony complex. The T1 comes from underneath and fuses to form the inferior trunk in relation to the corner pocket. So the formation of the inferior trunk can be clearly demonstrated, and we have described this in our recent publication in Regional Anesthesia Pain Medicine. As you can see, if you imagine that the red pain is the pain that gives you the neural stack, if you now sweep the transducer with a slightly tilting motion like so, if you now pan the transducer from a cranial to a caudal direction like so, you will now be able to see the fusion of the T1 with the C8. You can see here the C8 is lying on top of the first rib. The T1 is now coming from underneath. It swings across and then fuses with the C8. You can see here the T1 is coming from underneath. It swings around and comes to fuse with the C8 to form the inferior trunk at the corner pocket. So the C8 joins the T1 to form the inferior trunk at the corner pocket. So based on the sequential ultrasound imaging technique that I have demonstrated to you, I think it's fair to say we can very accurately identify the ventral ramus of C5, C6, C7, C8, and T1. You can also accurately locate the fusion of the C5 and 6 to form the superior trunk, the middle trunk, which is the continuation of the C7, and the inferior trunk, which is the fusion of the C8 with the T1 ventral ramus. I've also shown you that the superior trunk often trifurcates into a SPA, which is the suprascapular nerve, the posterior and anterior division. You may also see in some individual the divisions of the middle trunk into its anterior and a posterior division. It's more difficult to define the divisions of the inferior trunk because this often takes place, I think, behind the clavicle. In a recent publication, we've also demonstrated that SUIT is a reliable technique. You can accurately identify majority of the neural elements, particularly the C5 ventral ramus, the C6, C7, and the C8 ventral ramus, including the superior trunk, the middle trunk, and suprascapular nerve in 80 to 100% of individuals. The T1 and the inferior trunk are more difficult to identify, but even these elements are seen in about 40 and 60% of individuals respectively, as we did in this cohort of volunteer scans. We've also demonstrated that SUIT is a reliable technique in identifying these individual elements. It produces a very high inter-rater agreement when identifying the superficial elements, particularly the C5, 6, and superior trunk, is almost perfect with a kappa of 1. For the other elements, it's usually moderate to fair. This is not bad given that this is a new technique and we are all getting familiar with it, and I'm confident with time we'll only get better at identifying these various elements. So now the question that may be going through your mind is, why use SUIT? First of all, take a look at this video. In this, you can see the anomalous position of the C5 ventral ramus. You can see here, this is the C6, and you can see the C5 is actually located anterior on the anterior surface of the scalenus anterior muscle. In fact, it's not within the interscalene groove at this level. And in fact, you can see the C7, C6, and the C7 here. So the C5 usually comes quite caudally before it fuses with the C6 to form the superior trunk. So that is an anomalous location of the C5 ventral ramus. This is another situation where you can see the C5 ventral ramus in a small muscular compartment within the scalenus anterior muscle. It's totally separate from the other elements. It's only when it goes further down that it fuses with the C6 to form the superior trunk. We've also demonstrated that the T1 may not fuse with the C8 at the supraclavicular fossa. As you will see here in the sequence of images from left to right, you can see that this is the C7 based on the sonomorphology of the C7, so 6 and 5. You can see the neural stack formed by the superior trunk, middle trunk, and the ventral ramus. Also note there are many muscular bridges between these various neural elements within the interscalene groove. These are not often referred to in our region anesthesia literature, although it is very well known in anatomical literature. You can now see that the C8 is located on top of this osseous complex, and the T1 is coming from underneath. And normally it would, as I showed you before, it would fuse to form the inferior trunk in the corner pocket. But in this individual, as you see here, as we track it, you can see that the C8 remains isolated in the corner pocket, but the T1 now has gone medial to the subclavian artery and between the subclavian artery and the vein in an anomalous position on top of the first rib and in between the subclavian artery and the vein. This poses a challenge because if you are to perform a brachial plexus in this individual, supraclavicular brachial plexus block, then this connective tissue element barrier that is interposed between the T1 ventral ramus and the C8 may lead to inferior trunk sparing. As you can see here, we perform the injection at the corner pocket, and then we breach this connective tissue layer to inject selectively the T1, which was located medial to the subclavian artery. So this connective tissue barriers have been described as the costopleural membranes. These are the costopleural ligaments. They're often described as Zuckerlander-Sebelius ligament, and they are about 5 or 6 of them that may sometimes interfere with the T1 actually reaching its normal position, and has been described in the literature. Muscular bridges are also very common, as you can see here. You can see here there's a muscular bridge, large muscular bridge between the C6 and the C7 ventral ramus. Also, if you look carefully between the C5 and C6, there's another muscular bridge located between these. So they may indeed interfere with this, with the spread of the local anesthetic within the interscalene groove. So, in conclusion, why a suit? Why would you want to do a sequential ultrasound imaging as opposed to just place the transducer and perform the injection? I think for safety and efficacy, it is very important. Accurately identifying the anatomical structures relevant for brachial plexus are vital, as I have illustrated to you, that intra-root splitting of the ventral ramus of C6 and C7 may result in inadvertent intraneural injection if you misidentify the two components of the C6 or the C7. Muscular bridges are very commonly identified, as I showed you, and some of our future research, ongoing research is directed towards quantifying some of these muscular bridges. You can also identify anatomical variations that I illustrated to you. Various novel brachial plexus block techniques have been described in order to circumvent or avoid some of the complications that are common with interscalene brachial plexus block. And some of this is well known. Today, the superior trunk block is a very commonly performed technique to try and produce equally effective analgesia to an interscalene block, but produce lower incidence or minimize the incidence of phrenic nerve palsy or ipsilateral hemidiaphragmatic palsy. Also, anterior suprascapular nerve block have been described as a technique for analgesia for shoulder surgery, and we have more recently described selective trunk block, and we'll be discussing more about this very soon. May also have diagnostic application. You can see if you can accurately identify these various neural elements, then you can then say that yes, there is a neuroma of the C5 ventral ramus or a neuroma of the superior trunk. It may also be useful for dynamic ultrasound imaging when you are able to identify these structures and do dynamic effects of certain motor effects of function, muscular function that are related to these neural elements. So it may have a role in the future to more accurately perform dynamic ultrasound imaging. With these few words, ladies and gentlemen, I'd like to thank you for your attention. Okay, so I hope you found that interesting. I think now the first lecture sets the stage for what is to come. So in the next presentation, I'm going to talk to you and describe to you a technique that we have been investigating for some time now. We describe it as the selective trunk block, or SeTB. Now, selective trunk block, if you would say, is basically the principle is you're going to selectively identify the trunks and selectively inject them individually or separately. Now, since the innervation to the upper extremity either passes through all these three trunks or are given off like the suprascapular nerve is given off. So if you can selectively block these three trunks, then you can, in principle, produce anesthesia of the entire upper extremity except for the area innervated by the intercostobrachial nerve, which is T2. So you can block C5 to T1 by just blocking the superior, middle, and inferior trunk. So this is the basis of the selective trunk block, and I'm going to highlight more about this in the presentation. But in order to do so, you can see how important it is to be able to selectively identify these elements, and we will be illustrating this to you in the next presentation. Hello, I'm Manoj Karmakar. I bring you greetings from Hong Kong. I take this opportunity to thank the organizers for inviting me to speak at this meeting. Before I begin, I'd like to declare that I have no conflict of interest whatsoever relating to this presentation. During this presentation, my objective is to share with you a preliminary experience on a new region anesthetic technique that we describe as selective trunk block. It goes by the acronym SeTB. We've been working at trying to evaluate it as an all-purpose regional anesthetic technique for upper extremity surgery. The analogy would be whether we could use it like the spinal of the upper extremity, irrespective of the site of surgery in the upper extremity. Before we go into the details of selective trunk block, I think at this juncture it's important to address the issue as to why we need a regional anesthetic technique that can be used as an all-purpose technique or spinal anesthesia of the upper extremity, given that we have different techniques available to us in our armamentarium, like the interscalene, the supraclavicular, infraclavicular, and the axillary brachial plexus block. During an interscalene brachial plexus block, a transverse oblique scan is performed in the neck to identify the ventral ramus of the C5 and C6 located between the scalenus anterior and the scalenus medius muscle. The needle is inserted in plane from a lateral to medial direction, aiming for a periplexus location of the needle adjacent to the C5 and C6 ventral ramus, whereby the local anesthetic is injected to produce anesthesia and analgesia for shoulder surgery. So therefore, we target the C5 and C6 ventral ramus during an interscalene brachial plexus block and is preferred for shoulder and upper arm surgery. A limitation of this interscalene block is that inferior trunk sparing occurs in as high as 82% of individual. Therefore, it is not suitable for surgery at or below the elbow. Low interscalene brachial plexus block has been described to try and circumvent this limitation. However, even with large volumes of local anesthetic, although there is more distal spread of the sensory motor blockade, anesthesia or surgical anesthesia of the hand and forearm only develops in about 15% of individuals. Therefore, it would not be suitable for the entire upper extremity. Supraclavicular brachial plexus block is often described as the spinal anesthesia of the upper extremity because it produces very rapid onset of sensory motor blockade of not only the arm but also the forearm and the hand, and is traditionally not used for shoulder surgery because of the concerns of suprascapular nerve sparing. Inferior trunk sparing also occurs in as high as 30 to 35% of individuals, even with the corner pocket injection that has been described. Nevertheless, it has been successfully used for ambulatory arthroscopic surgery, albeit with the use of very large volumes of local anesthetic, sometimes up to 65 mils of local anesthetic, volumes that are rarely used in modern day regional anesthetic practice. Infraclavicular brachial plexus block targets the cords of the brachial plexus at the lateral sagittal infraclavicular fossa. It's used for surgery at or below the elbow. Axillary brachial plexus block targets the four major terminal nerves of the brachial plexus, i.e. the median, radial, ulnar, and the musculocutaneous nerve. It produces very rapid onset of sensory motor blockade of these four terminal branches. An axillary brachial plexus block is predominantly used for surgery distal to the elbow. The recent COVID-19 pandemic has surely brought a lot of doom and gloom across the globe, but with it, it has also brought a lot of opportunities. And one of these opportunities I'd like to share with you. When you look at patients who present for humeral fracture surgery, they can be challenging in that none of the currently available regional anesthetic techniques of the upper extremity can provide complete surgical anesthesia for these patients, particularly during this pandemic when most practices have been trying to avoid the general anesthesia in a quest to try and minimize aerosol generating procedures like intubation and spread of infection within the OR. Regional anesthesia has become the go-to for most of these procedures. But when you try and find a regional anesthetic technique for these humeral fracture surgery, particularly the upper humerus, then you're left with very little choice. Hybrid techniques have been described, i.e. a combination of axillary and interscalene brachial plexus block, described by Dr. Urme many years ago, interscalene axillary brachial plexus block, or an interscalene supraclavicular brachial plexus block, or as I alluded to previously, infraclavicular with a suprascapular nerve block. However, a limitation of these hybrid blocks are they require large volumes of local anesthetic, sometimes up to 50 mils of local anesthetic drugs. Sarah Madison and the group from San Diego, in their paper on ultrasound-guided root trunk interscalene block for hand and forearm surgery, described that it would be desirable to have an all-purpose brachial plexus technique for upper extremity surgery. It would change many years of our practice of using an individual technique and many different approaches to the brachial plexus. So with this, we suggested that selective trunk block would be a simple alternative to the hybrid brachial plexus block techniques for proximal humeral surgery. We've also demonstrated that the SeTB can be used to produce surgical anesthesia of the entire upper extremity in this case report. It is based on the principle that majority of the innervation to the upper extremity go through the superior, middle, and inferior trunk. So if you can selectively block the superior, middle, and inferior trunk, then you can, in principle, block the entire sensory motor blockade supply to the upper extremity. So therefore, it is vital that we are able to accurately identify the three trunks of the brachial plexus. And this is based on an ultrasound imaging technique that goes by the acronym SUIT. It's a sequential ultrasound imaging technique that we have recently described to identify the individual elements of the brachial plexus. The sequential ultrasound imaging technique is a transverse ultrasound scan sequence that starts from the supraclavicular fossa and identifying a few well-known sonomorphological features, you can determine accurately the various elements of the brachial plexus. In brief, it is a sequential scan over 7 contiguous sites starting from the supraclavicular fossa. You identify the C7 transverse process, and then further cranial to that you identify the C6 transverse process with the C6 ventral ramus. Thereafter, you identify the C5 transverse process with the C5 ventral ramus. The transducer is now manipulated in a caudal direction to see the fusion of the C5 and C6 to form the upper trunk, followed by the neural stack of the upper trunk, middle trunk, and the C8, and thereafter the formation of the inferior trunk at the corner pocket. So this starts by a scan at the supraclavicular fossa. You can see here the trunks and divisions of the brachial plexus are located superior and lateral to the subclavian artery. While for many this may be referred to as a bunch of grapes, but if you look very closely at this and you do a sequential scan, you can then say that this is indeed the suprascapular nerve. This is the posterior division of the upper trunk. This is the anterior division of the superior trunk. This is indeed the posterior and anterior divisions of the middle trunk, and this is the inferior trunk lying in the corner pocket relative to the subclavian artery and the first rib. Second, you translate the transducer slightly carefully to identify the C7 transverse process, which has a single posterior tubercle, and anterior to that lies the C7 ventral ramus, with the C6 lying contiguous and cranial to that position. Cranial to the C7 transverse process, the C6. The C6 also has a very pathognomonic or very typical sonomorphological feature. It has a very prominent anterior tubercle and a much smaller posterior tubercle, and the C6 ventral ramus lies in between the two as it's emerging from the intervertebral foramina. The C5 lies proximal to the C6. As you can see here, it's a much smaller ventral ramus in size compared to the C6 and the C7. From the C5, you translate the transducer in a caudal direction where you see the fusion of the C5 and C6 to form the superior trunk. The middle trunk, which is the continuation of the C7, lies distal to it, and caudal to that lies the C8 ventral ramus. This can also be identified by its position on top of the T1 transverse process and the first rib complex. You can see this large hyperechogenic line with this acoustic shadow. So this is a bone. So this is your T1 transverse process and the first rib complex. So this neural stack formed by the superior trunk, the middle trunk, and the C8 ventral ramus is our primary ultrasound window or the target one of the target ultrasound windows for the SeTB block. If you follow the superior trunk more distally, you can, in some individuals, see the very accurate separation of the superior trunk into a suprascapular nerve, a posterior division, and an anterior division. This arrangement from a lateral to medial has been described as spar of the brachial plexus. So it's also an important sonomorphological feature in the brachial plexus highway, where you can see the three divisions of the superior trunk. Caudal to that lies the middle trunk, and the C8 can be seen either on top of the first rib transverse process complex or sometimes even on top of the pleura, as you can see here in this individual. Once you have identified the C8, distal to that, you can now see how the T1 emerges from under the clavicle, under the first rib, beg your pardon, to join the C8 to form the inferior trunk. As you will see here, the C8 is located on top of the first rib. You can see the T1s coming from underneath to fuse with the C8 to form the inferior trunk at the corner pocket. As you see here, this is the C8. The T1 comes from underneath the first rib, and it goes around, swings around to join the C8 to form the inferior trunk at the corner pocket. Using the sequential ultrasound imaging technique, or SUIT, we've also demonstrated recently that it is possible to identify most of the superficial elements, particularly the C5, C6, C7 ventral ramus, including the superior trunk and the middle trunk with the suprascapular nerve, in about 90 to 100% of individuals. The T1 and the inferior trunk are more difficult to identify, but even these structures can be identified in about 40 to 60% of individuals respectively. We've also demonstrated that SUIT is a reliable technique in terms of when you look at inter-rater agreements. The inter-rater agreement of kappa was perfect for most of the superficial elements, as I alluded to, particularly the C5, 6, and the superior trunk, and it was moderate to fair for the other elements. This is not bad, given that this is a new technique that we are all becoming familiar with. With experience, I'm confident the results would be even. So now let's take a look at selective trunk block based on these basic fundamentals. SeTB is based on the principle that majority of the innervation to the upper extremity arise or pass through the three trunks of the brachial plexus. Therefore, targeted injections of the individual trunks of these brachial plexus using small volumes of local anesthetic, we hypothesize would produce surgical anesthesia of the entire upper extremity that should be adequate for surgery not only of the shoulder and of proximal humerus, but also of the elbow and the forearm, or a combination of either of any of these surgical procedures. So therefore, it is in principle has the potential to become an all-purpose regional anesthetic technique for upper extremity surgery by blocking the ventral rama of C5 to T1. And it is with these objectives that we set out to investigate this technique of SeTB. As you can see here, patient is lying supine with the ipsilateral arm in a neutral position, the head turned to the contralateral side. The ergonomics are like so, as you can see in the top left image. Under strict aseptic precaution, a transverse oblique scan is performed in the supraclavicular fossa, and then we identify the target acoustic window, as I mentioned before. It's the neural stack of the superior trunk, middle trunk, and the T1. C8, beg your pardon. So the neural stack of superior trunk, middle trunk, and the C8 on top of the transverse process of T1 and the first rib complex is the first neural target. Under local infiltration, the needle is introduced and injections of the superior and the middle trunk are performed. Thereafter, the needle is withdrawn, and using a second injection in local infiltration of the supraclavicular fossa, a further 10 mils of local anesthetic is deposited next to the inferior trunk at the corner, close to the corner pocket. So currently we are injecting 7 mils at the superior trunk, 8 mils at the middle trunk, and 10 mils at the inferior trunk, giving us a total of 25 mils of local anesthetic. This is from another perspective. You can see the patient is lying supine with the head turned to the contralateral side under strict aseptic precautions. A high-frequency linear transducer is being used to produce a transverse oblique scan of the brachial plexus. Once the target ultrasound window is achieved, under local infiltration, the needle is introduced to perform a periplexus injection of the superior trunk. The needle is redirected after the superior injection to inject the middle trunk, which is just coated to the superior trunk. 7 and 8 mils of local anesthetic, which is a combination of lidocaine and levobupivacaine currently with epinephrine. And then a second injection is performed at the supraclavicular fossa at the corner pocket of the subclavian artery and the first rib. In the sonogram, this is what you can see here. The C7 transverse process with this very typical sonomorphology. The posterior tubercle, you can see the C7, 6, and 5. The C5 and 6 fuse to form the superior trunk, you can see here. So it's the superior trunk, the middle trunk, which is continuation of the C7, and the C8, they are lying on top of this bony complex that I alluded to before. The first injection is performed in a periplexus location next to the superior trunk. It's withdrawn, redirected to the middle trunk, close to periplexus to the middle trunk. 7 and 8 mils of this local anesthetic mixture is injected at these two sites respectively. Thereafter, a third through a second skin puncture, the corner pocket is injected for the inferior trunk at the supraclavicular fossa. One must note that because the needle is maneuvered through the middle trunk, one must pay attention to the position of the dorsal scapular and the long thoracic nerve within the middle scalene muscle in this situation. Just a few video loops to demonstrate to you. You can see here, this is the scalenus anterior and the medius. So to your left is lateral. And you can see here, this is the T1 transverse process and first rib complex, on top of which lies the C8, and then the middle trunk, and the C5 and 6 forming the superior trunk. Then advance the needle from a lateral to medial direction. You place the needle in the periplexus position after saline hydrodissection, 7 mils of a combination, 1-to-1 combination of 2% lidocaine with 1 in 200 epinephrine and 0.5% bupivacaine is added, is injected at this level. Thereafter, the needle is redirected to the same skin puncture and repositioned adjacent to the middle trunk, which is a continuation of the C7 within the interscalene groove, and 8 mils of the local anesthetic mixture is injected. Once this is done, the needle is withdrawn and a second skin puncture is made at the supraclavicular fossa, and like a supraclavicular brachial plexus block, you now advance the needle. The only difference you find here is that because of the initial injection, there is usually hydrodistension of the supraclavicular fossa, and it makes it easy to place the needle within the subfascial elements of the brachial plexus at the supraclavicular fossa, where 10 mils of local anesthetic mixture is then injected. We've now gained quite a relative experience with respect to this, particularly when you're looking at proximal humeral. As you can see, this is a pathological fracture of the humerus undergoing intramedullary nailing. Patient is lying again supine here. After the block, you can see patient is in the head-up position in a semi-beat chair. So there can also be advantages because of the detrimental effects of general anesthesia on cerebral perfusion and reports of cerebral vascular accidents following surgery in some of these unfortunate patients. So if you can avoid it in this beat chair position by giving regional anesthesia with a more stable hemodynamics, it is desirable. You can see here patient is now listening to music through a headphone. They are sedated with dexmedetomidine. The respiratory function is monitored for any apnea or respiratory obstruction, and surgery continues under the effects of the SeTB, and thereafter you can see here the intramedullary nail has been placed. The proximal interlocking nails are placed at the upper head of the humerus, close to the head of the humerus, and then the distal interlocking nails will be placed closer to the elbow. A word of caution when you perform selective trunk block. The transverse cervical artery is very closely related to the superior trunk, as you see. It always, more or less in most of the individual, it goes on top of the scalenus anterior and then crosses over to the other side. But in some individual, it may also bisect the interscalene groove between the superior trunk and the middle trunk. So we believe it is imperative to identify these this artery so that you don't inadvertently puncture this artery or inject interarterially, especially if it is within the interscalene groove, and then perform the superior trunk block or the SeTB slightly above or below the plane at which the artery is located. So what have we learned so far? As part of our initial investigation, looking at the selective trunk block, I've shared with you the sono anatomy and the technique so far. Let's now take a look at the block dynamics and its effect on phrenic nerve function. In this cohort of 30 patients of different ages, mostly adult patients, undergoing a variety of operations from the proximal humerus to the hand and wrist, or a combination of one or the other, that was performed mostly under regional anesthesia and sedation, but there was a whole group of individuals who wished not to be sedated, so 23% of them had it with the regional anesthesia only. As you can see here, this is a graph showing you the sensory score from 0 to 100, 100 being normal and 0 being anesthesia, in the distribution of the axillary, musculocutaneous, radial, ulnar, and the median nerve. As you can see here, over a 45-minute observation period, there's a very rapid decline in the sensory scores. Take the red as a summary of the whole data. The onset of sensory block of the axillary, musculocutaneous, and the radial nerve are much more quicker as compared to the median or the ulnar nerve. This may be related to, again, the earlier injection of the superior and the middle trunk. This is a motor score. To your left is the mean motor scores, and to the right is the median and interquartile motor scores on a range from 0 to 2 in the Likert scale. You can see here that the motor onset of blockade of the axillary suprascapular, given that suprascapular does not have a cutaneous innervation, it only supplies the shoulder joint, but without a cutaneous innervation of the skin. It has musculocutaneous and the radial nerve. You can see here again the C5, 6, 7 components are much earlier affected than the C8 and T1. When we looked at the onset of sensory and motor blockade, defined as a sensory score less than or equal to 30 and a motor grade of less than or equal to 1 in the Likert scale of 0 to 2, you can see here that there is a rapid onset of sensory blockade in all the 5 nerves. The axillary, musculocutaneous, radial, ulnar, and the median, and the summary data also you can see here. There is almost onset of with as early as 10 minutes, and the motor grade, there's also rapid decline in motor function in all the major nerves evaluated. So much so that the onset of motor blockade of the axillary, suprascapular, and musculocutaneous nerves and the radial nerve are much faster when compared to the median nerve. The next question that we would like to address is, what is the effect on the phrenic nerve? As you can see here, this is M-mode ultrasound that we performed in our patients. We are able to perform them using in the supine position, and you can see here that the diaphragmatic excursion in the normal breathing, quiet breathing, and to your right is a diaphragmatic excursion on maximal deep breathing. And this is deep breathing, diaphragmatic exertion on deep breathing after the block. As you can see here, compared to the left, which is before the block, there is a rapid decline or decrease in there's a decrease in diaphragmatic excursion at 30 minutes. Also, when we looked at the sniff test, paradoxical movement could be detected in many individuals. As you can see here, there's a negative dip. That means the diaphragm is moving away from the transducer. So this indicates a complete paralysis of the diaphragm. So hemidiaphragmatic involvement, as defined by these criteria, that means the involvement less than 25 was no paresis. Anything more than 75% decrease in diaphragmatic excursion was complete, and between 25 and 75 was defined as partial, a criteria that's very frequently used to define hemidiaphragmatic involvement. We found that complete and partial hemidiaphragmatic involvement was detected in 80% of our patients with the dose that we used. Overall reduction in diaphragmatic excursion was about 62%, and paradoxical movement was detected in as high as about 30% of these individuals. A word of caution is that our patient studies had normal respiratory function, so given its very high diaphragmatic involvement, this would be a prohibitively high rate to be used in patients with respiratory disability. So in conclusion, selective trunk block is a novel regional anesthetic technique that we have successfully used for surgical anesthesia of surgical procedures involving not only the shoulder and the upper humerus, but also the elbow, forearm, and the hand. So we use it kind of a spinal anesthesia of the upper extremity, being particularly useful when we have used it in combination of our surgical procedures of involving not only the shoulder and the upper humerus, but also in combination with hand or forearm surgery. The phrenic nerve involvement of 80% is prohibitively high for it to be used in every patient as an all-purpose regional anesthetic technique. I think it would be too good to be true to be able to use it in every individual, like spinal anesthesia of the upper extremity. So patients who have respiratory disability would be a contraindication to the use of SeTB in the currently used doses that we are using. There may also be an impact of SeTB on teaching and learning of USGRA for the next generation of regional anesthesiologists, because using this simple single technique, you could perform majority, maybe more than 90% of individuals, you could perform upper extremity surgery irrespective of the site, but also when there is a need to provide anesthesia of combined sites in the upper extremity. There is need for future research and further randomized controlled trials are ongoing in our institution. With these few words, ladies and gentlemen, I'd like to thank you for your attention. Thank you very much. Okay, so I hope you found that interesting. I apologize, there's some repetition in the second from the first, but I guess sometimes a little bit of repetition is always useful. Now, I give me great pleasure to introduce once again the next speaker, Dr. Ke-Vin Chang. He's a musculoskeletal physician from Taipei. He's affiliated to the National University in Taiwan and the College of Medicine. He's quite a prolific author in terms of publications in the field of musculoskeletal sonography, particularly when you consider what he is going to speak to us today about, particularly the small nerves of the trunks of the neck. And I can see in the chat that many of you have been talking about, what about the dorsal scapular nerve? What about the long thoracic nerve? So to make all this simple for everybody, I would like to take this opportunity to welcome Ke-Vin. Ke-Vin, the stage is yours.
Okay, yeah. So thank you, Professor Karmakar, and it's my great honor to be the speaker of ISSPS 2021. My topic is ultrasound image to identify the small peripheral nerve of the upper extremity. So the following are the nerve I'm going to cover, including long thoracic nerve, thoracodorsal nerve, dorsal scapular nerve, intercostobrachial nerve, and the suprascapular nerve. So regarding the first three nerve, the long thoracic nerve, thoracodorsal nerve, and the dorsal scapular nerve. The nerve will be covered in the article that we published in 2017. As you can see, Professor Karmakar is also the author of this great article. So the article is open access. So if you are interested in how to scan those nerves, you can refer to this article. So the first nerve I'm going to address is the long thoracic nerve. Long thoracic nerve receives fibers from C5 and to C7 nerve root, and it goes through the costoclavicular space and then reach the lateral trunk, and then it innervates the serratus anterior. So if you want to scan the nerve at the cranial, at the cervical region, you can find the nerve pierce the middle scalenus muscle. At this region, there is another nerve that pierces the middle scalenus. That one is the dorsal scapular. So through this cadaveric picture, you can find the location of the dorsal scapula is actually cranial to the long thoracic, but both nerves pierce the middle scalenus. So sometimes when we scan both nerves, we get confused. So if you trace the long thoracic nerve to the truncal region, you can find that the nerve is besides the artery. The name of the artery is the lateral thoracic artery. And then you can find that the long thoracic nerve is on top of the serratus anterior. So if you want to trace the nerve at the cervical region, first, you put your transducer posterior to the sternocleidomastoid muscle, and then you can find that this is the superior trunk, and the long thoracic nerve will emerge from the posterior aspect of the superior trunk. And then the long thoracic nerve will enter the middle scalenus muscle. So if you move your transducer more distally, you can find the nerve will travel over the supraclavicular fossa. At the level of the supraclavicular fossa, you can find that the long thoracic nerve is embedded underneath the superficial fascia and of the serratus anterior. And the position of the long thoracic nerve to the brachial plexus is the same as when you scan it at the level of the interscalene level. So you can find the long thoracic nerve is posterior to the cord level of the brachial plexus. And if you move your transducer more distally to the infraclavicular level, you can find that the long thoracic nerve is still posterior to the brachial plexus and on top of the serratus anterior. And if you move your transducer more distally to the truncal region, you can find the nerve is besides the artery. The name of the artery is the lateral thoracic artery. And here we can find the long thoracic nerve had a branch, had divided into several branches. So sometimes it's very difficult to identify the nerve clearly. So here we usually use the lateral thoracic artery as the landmark for us to identify the long thoracic nerve. So let's watch the video to see how we scan the nerve. So at the cranial, at the cervical region, we put our transducer posterior to the sternocleidomastoid muscle. And then you can find the nerve emerge from the posterior aspects of the brachial plexus. And it will reach the supraclavicular level once it pierces the middle scalenus. So at the supraclavicular level, you can find the nerve is deeper to the brachial plexus. And another landmark for you to recognize is the suprascapular nerve. And the long thoracic nerve is on top of the serratus anterior. So sometimes if you can locate the fascial plane of the serratus anterior, you can easily identify the nerve. But if you encounter patients with serratus anterior atrophy, you will find difficulty to find the nerve because lack of contrast. So if you move your transducer to the truncal region, and then the truncal region, the nerve becomes smaller. So we usually use the artery as a landmark. and then you can find the nerve course on top of the serratus anterior. So this is the article written by my friend Dr. Libasama, and she used a high-resolution sonography to visualize the long thoracic nerve. The method for her to scan the nerve is the same like us. First, they look for the nerve inside the middle scalene, and then at the supraclavicular level, they use omohyoid suprascapular nerve to help locate the long thoracic nerve. So another muscular landmark for us to recognize is the posterior scalene muscle. So once you find the long thoracic nerve pierce the middle scalene, you would find the posterior scalene posterior to the long thoracic nerve. So why do we have to recognize this nerve? Because in patients with winning scapula, the main cause is the injury to the long thoracic nerve. So we can use ultrasound to identify whether the nerve is swollen or not. So here, this is the nerve at the abnormal site. You can find the nerve is swollen compared with the normal site. So another nerve is the thoracodorsal nerve. Thoracodorsal nerve is the branch of the posterior core of the brachial plexus. As you can see, the nerve is on top of the latissimus dorsi. So we know the main function of the thoracodorsal nerve is to innervate the latissimus dorsi. So how to scan it? First, you have to let a patient open the axilla to expose the infraaxillary region. And then here you can find this is the serratus anterior, this is the latissimus dorsi. Once you find the latissimus dorsi, you can locate the thoracodorsal nerve. The thoracodorsal nerve is besides the thoracodorsal artery. So you can use this way to help you identify where the thoracodorsal nerve is. And another important thing is if you want to check whether the nerve is swollen or not, sometimes we have to use long axis view to have the long axis of the nerve to see if there is a focal narrowing. And another important thing is when we scan those nerves, we have to use artery as a landmark. For the long thoracic nerve, we use the lateral thoracic artery. So we can scan this artery along the middle axillary line. And for the thoracodorsal nerve, the artery we used for locating the thoracodorsal nerve is the thoracodorsal artery. And there is also a branch of the axillary artery. So another nerve is the dorsal-scapular nerve. Through this cadaveric picture, we know the dorsal-scapular nerve innervates the levator scapula and the rhomboid muscle group. So just like we presented before, the dorsal-scapular nerve is also a nerve pierce the middle scalene. Dorsal-scapular nerve is the first branch of the C5 nerve root. So if you scan the cervical nerve root at the C5 or C6 level, you can see the dorsal scapular nerve emerge from the posterior aspect of the nerve root. And the location of the dorsal scapular nerve is cranial to the long thoracic nerve. So you can find the long thoracic nerve first from the caudal to cranial scanning. And then once you find the long thoracic nerve, you can sequentially identify the dorsal scapular nerve. So how to find the nerve? First, we place our transducer at the interscalene level. So once you see the C5 nerve root emerge from the intervertebral foramen, you can find the dorsal scapular nerve has already entered the middle scalene. So its location is between the C5 and the C6 nerve root. So once you move your transducer more distally, you can find this nerve. emerge from the posterior aspect of the middle scalenus, and then enter the space between the levator scapula and the underlying muscle. So let's watch the video to see how we scan this nerve. First, we place our nerve posterior to the C5, and then you can find that the small nerve emerge from the posterior aspect of the cervical nerve root. And then it will enter the space underneath the levator scapula. So this is the way that we can use ultrasound to identify the dorsal scapular nerve at the cervical level. But we know the dorsal scapular nerve is a nerve that innervates the levator scapula and the rhomboid muscle group. So how can we locate the nerve at the posterior aspect of our trunk? First, we place our transducer medial to the scapular spine, medial to the middle scapular border. And then you can find that the most superficial layer of the muscle is the trapezius. So underneath it could be the rhomboid major or rhomboid minor. And then you can find the dorsal scapular artery underneath the rhomboid muscle group. And then you can see the intercostal muscle is between two ribs. So the dorsal scapular nerve will be seen besides the dorsal scapular artery. So once you see the nerve, you can pierce the transducer in long axis. Then you can highlight the nerve in its long axis. Because sometimes in patients with dorsal scapular nerve entrapment, we will use long axis view to hydrodissect nerve to relieve the symptom. So this is the image showing the vasculature near the scapula. As you can see, the dorsal scapular artery is the branch of the transverse cervical artery, and it will cross at the medial aspect of the scapula. So at the middle aspect of scapula, we can use the dorsal scapular artery as a landmark for us to recognize the correct fascial plane. And let's use ultrasound to scan the nerve. Yeah, this is the video. First, we place our transducer medial to the middle scapular spine, and then we can find the nerve medial to the dorsal scapular artery, and it is interposed between the rhomboid muscle group and the intercostal muscle or rib. So once you recognize this nerve, you can pierce the transducer in the long axis to follow this nerve. So this is the article written by Professor Stanley and my colleague, Dr. Hong and Dr. Su. And then this is the later to editor commenting the injection of dorsal scapular nerve entrapment. So here, as you can see, they provide a well-edited picture to elaborate the dorsal scapular nerve and the dorsal scapular artery. As you can see, the muscle at this region is quite complicated. For example, you can see if you put your transducer over the proximal region, you can find that the most superficial muscle is the trapezius, and the levator scapula will be underneath it. And then you can find the artery, and the nerve will be beside it. And then move your distally, you can find that the size of the levator scapula is decreased, and then you can still find the consistent location of the dorsal scapular nerve against the dorsal scapular artery. So because the muscle at this region is very complicated, so in 2019, we wrote a later to article to describe how to scan the muscle that attach to the middle scapular border. So the muscle we are going to elaborate include the levator scapula, rhomboid minor, and the serratus anterior. So this is the cadaveric picture. In the cadaveric picture, you can identify this is the scapular spine, and this is the middle scapular border. This is the supraspinatus. This is the levator scapula. So here you can find that the course of levator scapula is actually quite vertical. So levator scapula emerge from the posterior aspect from the posterior tubercle and attach to the middle scapular border. So at the distal part, you can find that the levator scapula has already become a tendinous part. So if you check the muscle at the medial side, you can find two muscles. Another one is the rhomboid minor and the rhomboid major. So let's see the cross-section of cross-section image that pass through the middle scapular border. Here we can find this big muscle at the supraspinatus fossa is the supraspinatus. And this is the middle scapular border. And the structure medial to it is the levator scapula. Just like we presented before, the levator scapula will attach to the middle scapular angle, and the rhomboid minor will be middle to the levator scapula. And of course, the bigger muscle superficial to the levator scapula, and the rhomboid minor would be the upper or middle trapezius. And another muscle that is located anterior to the scapula is the serratus anterior. As you can see, the serratus anterior is actually very big. So here we can find if we put our transducer at the supraspinatus fossa, and then we let our transducer move medial to the middle scapular border. We can find that the most superficial layer is the trapezius, and the levator scapula will be underneath it. And the structure with a triangular shape, this is not the levator scapula, this is the serratus anterior. And the serratus posterior superior will be underneath the levator scapula and the serratus anterior. So how can we identify that this muscle is the serratus anterior? We can pivot our transducer to 90 degrees, and then we can find that the serratus anterior emerge from the anterior surface of the scapula and attach to the rib. So if we move our transducer more distally, we can find the size of the levator scapula decrease, and the size of rhomboid minor muscle increase. And then we can also find the serratus anterior muscle become smaller and smaller until we cannot identify it. And then move your transducer more distally, you can find that the levator scapula has become a tendon and attached to the middle scapular border. And the rhomboid minor muscle would be fully emerge from the undersurface of the levator scapula. So just like the name rhomboid, rhomboid means a quadrilateral shaped structure. So you can find that this muscle is shaped in a quadrilateral. It has a quadrilateral shape. So let's use dynamic image to identify which muscle you are scanning. So first, we put our transducer middle to the scapular border, middle scapular border, and then we change our transducer 90 degrees. And then you can find that the initially triangular shape serratus anterior will be seen in its long axis. So you can find that the muscle emerge from the anterior surface of the scapula and attach to the rib. So this is how we can confirm this muscle is a serratus anterior instead of the levator scapula. And if we put our transducer more distally in the horizontal plane, first you can find the levator scapula. This is a rhomboid minor. And then you can find the size of the levator scapula become very smaller, and it's become a tendon attaching to the middle scapular border. And this is a rhomboid minor. And our dorsal scapular nerve will be underneath the rhomboid minor muscle. So another nerve we are going to cover is the intercostobrachial cutaneous nerve. This is the cutaneous nerve. So if you want to know how to scan those cutaneous nerves, you can refer to our article published in 2018. This article, we collaborate with the master of musculoskeletal ultrasound, Carlo Martinoni. And then in this article, we also provide lots of video, so you can learn how to scan the cutaneous nerve by yourself. So let's look at this cadaveric picture. Here we can find the median nerve. This is the ulnar nerve, and the nerve posterior to, besides the ulnar nerve is the medial antebrachial cutaneous nerve, and another nerve located, that is located more posteriorly is the medial brachial cutaneous nerve. And the intercostobrachial cutaneous nerve would be, first you can see it's located underneath the pectoralis minor muscle, and then it will emerge from the second intercostal space, and then cross to the distal part on top of latissimus dorsi. So when we scan in the latissimus dorsi, can be our landmark to help us to identify the intercostobrachial cutaneous nerve. So how to locate those cutaneous nerve? First, you have to let the patient open the axilla and put your transducer at the middle posterior forearm. And then you can find the subcutaneous layer. You can locate two nerves. One is the medial antebrachial cutaneous nerve. The other is the medial brachial cutaneous nerve. The location of the medial antebrachial cutaneous nerve is anterior to the middle brachial cutaneous nerve, and it will cross besides the basilic vein. And then you can find if you move your transducer to the middle of the arm, and you can find that the medial brachial cutaneous nerve is located posterior to the ulnar nerve. So if we move our transducer on top of the latissimus dorsi, you can find the intercostobrachial cutaneous nerve is on top of latissimus dorsi. And then if you move your transducer more cranially, you can find the nerve will be on top of serratus anterior, and then will be submerged into the second intercostal space. So you may ask me why is it important to locate those cutaneous nerve? Let me provide a case. This case complains of pain over the arm and the forearm. So we use ultrasound, we can find that there is a lipoma on top of it, but underneath the lipoma is the medial antebrachial cutaneous nerve. So the patient usually complains of frequent electrical shocking sensation when we rub against her forearm. And also, we also identify another lipoma on top of the medial brachial cutaneous nerve. Likewise, if you compress this area, the patient would have the electric shocking sensation. So because those cutaneous nerve is very superficial. So besides, we can use this nerve for local anesthesia. And then another important thing is if there is a space occupied lesion besides it, it could be compressed and cause symptom. So the last part is the suprascapular nerve. So the suprascapular nerve, traditionally we use when we scan it at the supraspinatus fossa. So at the supraspinatus fossa, we can find that the suprascapular nerve is underneath the deep fascia of the supraspinatus. And this image is published in American Journal of Physical Medicine and Rehab. And this article, this image has been chosen as the cover page of this issue. So, but we know the suprascapular nerve is the branch of the brachial plexus. So its location, just like what Professor Karmakar has already presented, is located posterior to the brachial plexus. And we can use the omohyoid as a landmark to see the nerve underneath the omohyoid. So as a PMR physician, we also want to know whether the nerve would change in certain kind of patients. So in 2018, we performed a clinical study to evaluate the size of the suprascapular nerve at a different region. So in our study, we find when we measure the cross-sectional area of suprascapular nerve, we find that the cross-sectional area of the nerve at the distal part is larger than that at the proximal part. So we go back to see the categorical image. We find because at the distal part, the nerve started to give several branches. So if we include all the branches together, we can find the size of the nerve at the distal part is larger at its proximal part. So what is the implication of this study? If you want to use ultrasound image to diagnose the patient to have suprascapular nerve neuropathy, you have to use a different standard value when you scan the nerve at the different sites. So later we apply this technique for patients for aging patients with shoulder pain. Again, we use the same technique to locate the suprascapular nerve at the brachial plexus level, the level of the supraspinatus fossa, and the level of the infraspinatus fossa. So we measure the cross section. And in our study, we find that in aging population, we can find at the supraspinatus fossa. In patients with supraspinatus full thickness tear, we can find that the nerve cross-sectional area is larger than those without the full thickness tear. So here, let's look at the ultrasound image. This is the image from a person without the supraspinatus tendon full thickness tear. This is image from another person with supraspinatus full thickness tear. As we can see, in this patient, the supraspinatus muscle become atrophic, and the size of the suprascapular nerve is enlarged. So we propose a theory. We think in the aging population, they may suffer from muscle degeneration, so-called sarcopenia. And those patients would have shoulder impingement easily. And then eventually they would have a tear of the rotator cuff tendon. So once the tendon or muscle is torn, the torn muscle will retract the nerve to the medial aspect and cause nerve entrapment. And then the patient with neuropathy and the subsequent shoulder pain. So we know the suprascapular nerve is a great procedure for us to treat recalcitrant shoulder pain. So in our meta-analysis, we probe the issue whether the suprascapular nerve block is effective for the chronic shoulder pain. So this is the traditional way to perform the suprascapular nerve block. We block the nerve at the supraspinatus fossa. So we can find that using the suprascapular nerve block, the effect is better than physical therapy only and the placebo injection for the treatment of chronic shoulder pain. And it has equivalent effect to the intra-articular corticosteroid injection. And for patients who receive shoulder surgery, we also find that using the suprascapular nerve block can reduce postoperative shoulder pain and also reduce the amount of opioid use, because the overuse of opioids would cause the postoperative nausea. So we can find using the suprascapular nerve block can reduce the postoperative nausea. And we also apply the proximal suprascapular nerve block technique for patients with malignancy associated shoulder pain. And we find that most of patients had good response. But if you want to use a proximal suprascapular nerve block, the dose of the block is something that we have to consider. So in this regard, we wrote a letter to article commenting an article comparing the proximal and the distal suprascapular nerve block. Because from this picture, we can find the brachial plexus and the long thoracic nerve is very close to the suprascapular nerve when we block the nerve at its proximal region. So in this sense, if you want to block the suprascapular nerve at the proximal region, it's better to use small volume. For example, 2 to 4 milliliter of lidocaine would be suitable. Okay, thank you very much. If you are interested in my talk, you can refer to the MSK Ultrasound Club in Facebook. There are so many experts join this forum, and you are welcome to join it. Thank you very much.
Thank you, Ke-Vin, for the wonderful presentation. I think this highlights that there's a lot for everybody to learn. And it's very difficult to assimilate all this knowledge and information in a single session. So to facilitate all this, we are going to upload all these videos once the ISSPS webinar series is over onto ISSPS TV. This will come to you through YouTube. So if you're a registered person through our website, then you will get regular notifications of these uploads onto ISSPS TV. So if you are still not registered, I would urge you to please register. I'm not saying hit the button here or ring the bell there, but please do register to the website so that we can send you the appropriate information at the right time when all this goes on to the ISSPS TV website. So hopefully that should cover many of the questions that many of you have been asking. How can you access these lectures? Next, I'm going to cover another topic that also comes from our stables in our hospital in the Prince of Wales, where we evaluated or we define the costoclavicular brachial plexus block. It's slowly becoming a technique of choice, but not only for upper extremity surgery, but many are also using it for shoulder surgery. So in order to really understand this, you have to understand the block in detail. Before I begin, I'd like to again declare I have no conflict of interest, but whenever you see this red star, do pay attention because it is highlighting an important take-home message. So this is going to be the message for you. The red star will be the take-home message. So my objective is to demonstrate to you how ultrasound imaging is really helping us refine regional anesthesia. Like I mentioned to you previously about the SUIT, the SeTB, and now costoclavicular brachial plexus block. And there are many other techniques that other researchers have refined in our literature. So firstly, in order to understand this, we need to understand why you need another brachial plexus block, whether it's called costoclavicular brachial plexus in this case. I will then discuss the relevant anatomy, the ultrasound imaging technique with the sono anatomy, and then present to you the block dynamics that a costoclavicular brachial plexus does, and then review the literature for you, including present some of our own work as to how it compares with other traditional techniques. Now, when you do a costoclavicular brachial plexus block, it's a proximal infraclavicular brachial plexus block targeting the cords of the brachial plexus at the costoclavicular space. Now, if I asked you, what is the most popular infraclavicular brachial plexus block technique that you are aware of? I think majority would say that it is the lateral sagittal infraclavicular brachial plexus block technique. In this, you perform a sagittal scan at the lateral infraclavicular fossa, like so, whereby you are visualizing the cords of the brachial plexus underlying the pec major and the minor muscle. To your left is cranial, to your right is caudal, and you visualize the second part of the axillary artery, and the cords are usually aligned along in relation to this second part of the axillary artery. It's usually described that the lateral cord is about 9 o'clock position, the posterior cord is at 6 o'clock position, and the medial cord is between the axillary artery and vein. And some of the basis of performing the lateral sagittal infraclavicular brachial plexus block and its simplicity is related to this, that so if you can perform a periarticular injection around the second part of the axillary artery, in majority 95% of individuals, you will be able to block the lateral, posterior, and the medial cords, and therefore it be effective to produce brachial plexus anesthesia, and therefore effective for surgery at the elbow or below the elbow. So this is just a video to show you using a high-frequency linear transducer in a sagittal plane. In our case, we have the arm abducted to about 90 degrees, where you can now see from anterior to posterior the pec major and the minor, and deep to it is the second part of the axillary artery. But now, ladies and gentlemen, you may be wondering, where are the three cords that I showed you in the cartoon? In fact, in this sagittal sonogram, you'd agree if I said that you can only see one of the cords here, and because of its position, we can say that this is indeed the lateral cord. The other cords are often not so clearly visualized in most individuals. So therefore, there lies certain limitations of performing lateral sagittal infraclavicular brachial plexus block. Firstly, the cords are located at a depth, usually much deeper than a supraclavicular or an interscalene brachial plexus block that we discussed previously. More importantly, the cords are often separated from one another, and there is literature that has demonstrated that there are wide variation in the position of the cords at the lateral sagittal infraclavicular fossa. And as I also showed you that three cords are rarely visualizing in a single sagittal ultrasound window. That doesn't mean that you can't identify the three cords. If you do a dynamic scan proximally and distally, and you're familiar with the anatomy of the cords from a proximal to a distal side, then you can track the individual cords, and then you can then say for sure, yes, this is the posterior cord and this is the medial cord. So therefore, again, having a systematic scanning approach is very vital when you are looking for the three cords at the lateral sagittal infraclavicular fossa, because they will not be saying, hello, I'm here, because you'll have to find them in their respective positions. It is for this reason relatively large volumes of local anesthetics are used to circumvent the inability to identify these cords, hoping that large volumes will spread to these cords and produce the blockade. And also multiple injections have been shown to be more effective than a single injection. Now, when you use a catheter, where do you place a catheter now that you have three cords? So it's usually placed at the posterior part of the axillary artery. That's usually at about 6 o'clock position. You place the needle like so from a cranial to caudal direction, and you place it at 6 o'clock, hoping that it would encompass all the three cords. The local anesthetic would. Now, the problem with that is that when you do a primary block, you inject a large volume, so you get a very effective primary brachial plexus block. However, in the postoperative period, when you run infusions of about 6 to 10 mils, usually 0.1 to 0.2 mils per kilo per hour, then you have regression of the primary block, and often there will be secondary block failure in the territories of the lateral or even the medial cord in that respect. So therefore, one of the limitations of lateral sagittal infraclavicular continuous techniques are the secondary block failure is very, very common. Furthermore, you can see here that the minimum effective volume that is often required to produce infraclavicular brachial plexus at the lateral sagittal is about 35 ml. Now, that's an exceedingly large volume given today's practice of using relatively small volumes of local anesthetics. So in my review of the literature, I found that actually the lateral sagittal infraclavicular fossa is not a very good location when you come to performing a brachial plexus block. When you have other sites which are more proximal, where the three cords are more clustered together and are more easily accessible at a more superficial location. So therefore, In this letter to the editor, we wrote saying that the costoclavicular space is a more desirable location to perform infraclavicular brachial plexus block. Because you can see here that the cords of the brachial plexus are indeed clustered together, and they're very consistently anatomy in this costoclavicular space. And I will come to that in a moment. It is indeed deep to the clavicle and posterior to the clavicle between the subclavius muscle and the serratus anterior. Now, in this case, you can see these are the upper slips of the serratus anterior that often overlie the second rib, and this is often referred to also as the serratus magnum, as Ke-Vin had alluded to in his presentation with the long thoracic nerve. So when you talk about the costoclavicular space, say 4 or 5 years ago, it was really poorly understood in the anesthesiology literature, despite the fact that in the radiology literature it's quite commonly described. As you can see here, Dr. Demondian and the colleagues in radiology have indeed described the costoclavicular space as a space deep and posterior to the clavicle, where the cords are clustered together, lateral to the first part of the axillary artery. So when you consider people ask me, how did you think about this? I said, I never thought about this. It was not my discovery. I just found the literature, and I found that there was a location that was so close yet so far from the lateral sagittal infraclavicular fossa that I thought would be more conducive when you wanted to produce brachial plexus block, which is reliable, which is consistent, and would block all the 3 cords of the brachial plexus. So you can see here, the 5 represents the posterior cord, the 6 represents the lateral cord, and the 7 represents the medial cord. So if you look at the anatomy that I will be describing shortly, it is indeed very consistent, and this is the arrangement that you will see consistently from one patient to another. So as you can see here in this cadaver dissection, if you may, this is in the comfort of your home that I performed from the National Medical Library. You can do this in the visible human server. You can see the cords are indeed located lateral to the artery in this position. And this is again to show you how the cords are actually related posterior and deep to the clavicle and in relation to the serratus magnus muscle in the costoclavicular space. In fact, if you look at the literature, performing infraclavicular block at the proximal site is not very original. It has been described much more earlier. And if you look further, I'm sure there is more further literature beyond 1995 where folks have performed brachial plexus at a much proximal site. It's just today we call it the costoclavicular brachial plexus block. In fact, Kilka described it in 1995 as a proximal infraclavicular brachial plexus block as a Kilka technique. As you can see here, this is our good old friend Belen Jose Maria from Barcelona in this publication performing a Kilka technique just distal to just below the midpoint of the clavicle. They introduced the needle directly posteriorly. We were using nerve stimulation, so your patient cannot be anesthetized with muscle relaxants. In this case, I think it's just sedated. And you look for a response of the lateral cord, which usually, because the lateral cord is usually more superficial, will be the first one to be in contact with the needle. And then in those days when we didn't have ultrasound, one of the suggestions or advice that were often were provided is when you get a lateral cord, and if you perform the injection, you get often sparing of the medial cord. You can see why, because the medial cord is indeed located posterior to the lateral cord in this sagittal section. The suggestion was that you should, once you get a lateral cord response, you should insert the needle deeper till you get a medial cord. So now you can say that, oh my God, we were probably going through the lateral cord in most cases to elicit a medial cord response. But fortunately, nothing happened in those patients that we often performed the Kilka technique. Cryomicrotome cadaver dissection studies have also shown that the anatomy of the cord, relationship of the cords in relation to the first part of the axillary artery is very consistent. You can see here the green represents the medial cord, the yellow represents the lateral cord, and the orange represents the posterior cord. And these are consecutive sections from a medial to lateral direction. I think they're about 5 millimeters apart. And then you can see that as the cords go laterally, you can see they still maintain a very consistent anatomical relationship with relation to the cord. Now, for this discussion, I like to highlight a few other anatomical landmarks, or if I may, that will be useful when we perform the scan. The first one is the cephalic vein. You can see here the cephalic vein enters the deltopectoral groove, and then it swings across over the brachial plexus to join the cephalic vein medial to the axillary artery here. This is the first part of the axillary artery. Deep to it is the second part, and distal to the inferior border of the pec minor is the third part of the axillary artery. And you can see how the cephalic vein swings over to join the axillary vein. Now, why this is important? Because while you are performing your scan at the costoclavicular space, if you happen to see the if you see the cephalic vein, it's a telltale sign that your scan is too distal. So you need to move your transducer further, more cephalad. Also, it is not uncommon if you apply a lot of pressure, you may indeed compress this vein and inadvertently puncture the cephalic vein. Probably not much consequence, but it's something that one needs to keep in mind. For this discussion, also, let's describe the section which is above the upper border of the pec minor, or the medial border of the pec minor, and the lower border of the clavicle as the medial infraclavicular fossa, and anything that is deep to the pec minor as the lateral infraclavicular fossa. So when you look at the sagittal scan at the medial infraclavicular fossa, like we did when you performed the Kilka technique at the midpoint of the clavicle, and you inserted a needle perpendicular to and below the inferior midpoint of the lower border of the clavicle, this is the anatomy you would see. You can see here, this is to your left is cranial and to your right is caudal. You can see the acoustic shadow of the clavicle. And then anteriorly, you can see the clavicular head of the pectoralis major muscle. And it goes and attaches to the clavicle. And deep to that is the subclavius muscle. This is subclavius because it's attached to the clavicle. And deep to that, you will see the pec minor, the upper border of the pec minor. And attached between these two is the clavipectoral fascia. You can see how the cephalic vein is coming from lateral to medial to join the axillary vein here. And then deep to the subclavius muscle, you can see the serratus magnus, which is the serratus anterior. That's often attached to the second rib here, in this case, behind the clavicle. So again, this is sometimes erroneously counted as the first rib. Actually, you can't identify the first rib below the clavicle with ultrasound. It's usually the second rib that is the first sonographically recognizable rib deep to the clavicle. So you can see here between the serratus anterior and the subclavius, there is a hypoechogenic space in which the three cords of the brachial plexus are clustered together in a hyperechoic matrix of connective tissue. This is the lateral cord, most superficial to you. Deep to that is the medial cord. So if you remember that the lateral cord is always superficial to the medial cord, and the posterior cord is always cranial and lateral to both these cords if you did a transverse scan. So this arrangement has been described as a Phrygian cap. In France, they use this kind of cap where you can see it looks like a Phrygian cap that is there on this statue, as you can see here. So this is the first anatomical study that we performed in our series looking at the anatomy of the costoclavicular space. So in the images that you will see from here on, whether they are cadaveric or ultrasonographic, to the top would be your cranial and to your left would be lateral, irrespective of the image that you see here. So you can see here, this is the clavicle, and deep to the clavicle, you can see the subclavius muscle. You can see the axillary vein. Obviously, it's a cadaver, so it's collapsed. You can see the axillary artery, and you can see the origin of the thoracoacromial artery from the first part of the axillary artery here. And lateral to that, you can see the cords of the brachial plexus. Now here, the most superficial is the lateral cord. You can see the posterior cord, which is the lateral most of the three cords. Actually, you can't see the medial cord because it is located deep to the posterior cord. Now, if you cut off the midsection of the clavicle, you can see now how the subclavius muscle is related to the clavicle, and how the neurovascular structures are aligned in the at the costoclavicular space. You can see the vein, the axillary artery, and the lateral and the posterior cord. If we now retract the lateral cord medially, you can now see that deep to the lateral cord, you can now see the medial cord, which is much more deep in location. This is an anatomical section to show you the arrangement of the cords. They are all clustered together lateral to the axillary, first part of the axillary artery, I beg your pardon, and they are lying on top of the second rib and in relation to the serratus magnus muscle. Histologically, also in this location, and we discussed at length about this during our brachial plexus session with the connective tissue sessions in the last webinar. You can see here, this is indeed the lateral cord. You can see there are two fascicles of the lateral cord here, and the 6 represents the epineurium of the lateral cord. The posterior cord, as I said, is more lateral, and this is a lateral transverse axial section here. And this is your medial cord. Medial cord is always deep to the lateral cord. So this arrangement is very consistent, and you will see this again and again as we perform these blocks. So having the 3 nerves or the 3 cords clustered together so close in this costoclavicular space, to me occurred that it would be good, because now if I could place my needle in between these cords, then I not only have a recipe for having a very high success rate of all the 3 cords, but I could also place a catheter that would now be ideal for anesthesia of all the 3 cords, and possibly that too with using a relatively small volumes of local anesthetic. So that is actually the fundamental basis of a costoclavicular brachial plexus block. You can see here, when you look at the sagittal and the transverse view in the same in these location, you can see this is the Phrygian cap arrangement of the lateral anterior, medial posterior, and then the medial cord posterior, and the posterior cord being more superficial. And when you look at it in the axial view, transverse view, you can see this arrangement. So now, once we understood the anatomy, we went on to perform the scans and develop the block. In a transverse scan, you use a high-frequency linear transducer, usually place it below the clavicle, just about the midsection of the clavicle. But having a systematic approach or a sequential approach with anything makes it more consistent. So I will try and hopefully demonstrate that to you about the costoclavicular scan, as I did previously with the interscalene in the above the clavicle with the interscalene block. So you can see here, this is the orientation in which the ultrasound beam is insonated. You can see it's aimed to insonate the second rib, so that if you can see the second rib and the serratus anterior muscle overlying it, then the anatomy, intervening anatomy becomes much more clear. So keep that in mind. When you are performing a scan, you have to dynamically tilt the probe slightly Ke-Vin so that you can insonate the second rib. So don't always try to look for the cords at first. Your objective, if you can get a good view of the serratus anterior and the second rib, voila, your cords will be right in front of you. This is the ergonomics that we use. You can see here, the arm is abducted. So one of the limitations of the costoclavicular scan is that the technique that we describe is that the arm has to be abducted to perform the injection from a lateral to medial direction, and I will come to that in a minute. We do the scan in 5 sequential steps, as you can see here. Some of it is redundant as far as the injection technique, but it gives you a good understanding of the adjacent anatomy, and at the same time, it tells you when your scan is not in the appropriate space. So as the volunteer here, you can see a linear scan is performed directly over the clavicle first. This is a good starting point because this is something that you can always identify. And then you slip the transducer just below the clavicle. You'll now see the pec major muscle, and you can see the subclavius. And then, as I said, in a slightly more caudal direction, you can see the cephalic vein coming from a lateral to medial direction. It actually swings over the three cords of the brachial plexus in the medial infraclavicular fossa. And at the costoclavicular space, you can see the three cords are actually clustered lateral to the axillary artery and deep to the subclavius muscle here and overlying the serratus anterior muscle. Look, you can see the anterior border of the serratus anterior very clearly. That's when your beam is at right angle to the nerves. So that's when you're going to see it best. Okay, this is a quick recollection. You can see the first window would be your clavicle. You just drop it underneath the clavicle, and you can see now the clavicular head of the pectoralis major, the subclavius. Of course, the transducer has to be tilted slightly cephalad till you can see the serratus anterior and the second rib very clearly. And lateral to the axillary artery, you can see a cluster of these three cords. The one that's most superficial to you is the lateral cord. Deep to that is the medial cord, and the most lateral of them all is the posterior cord. Again, if you go slightly more chordad, now you see the subclavius muscle is not visualized. So this is not a costoclavicular space anatomy. This is indeed an image of the upper part of the medial infraclavicular fossa, where you can see the cephalic vein coming from a lateral to medial direction. But at the same time, you can see that the three cords of the brachial plexus are very clearly identified. Again, the relationship remains the same. You can see the lateral cord, the medial cord, and most lateral of them all is the posterior cord, lying on top of the serratus anterior muscle. If you go further chordad, you can now see the pec major and the minor muscle, and deep to that is the axillary, second part of the axillary artery and the vein. You can now see the emergence of the thoracoacromial artery. This is indeed the first branch of the one of the main branches of the axillary artery, and it's usually given off either above the pec minor muscle or just at the upper border of the pec minor muscle. It also branches into two divisions, and this again divides into two branches. If you want to remember the various branches of the thoracoacromial artery, remember the mnemonic that cadaver are dead people. Aren't they? Cadaver are dead people. So you have a clavicular branch, you have an acromial branch, you have a deltoid branch, and then you have a pectoral branch. So these two give off the lateral branches, two lateral branches, and these give off the two medial branches. So this is a sequence of scan that I just referred to, from the clavicle to the costoclavicular space to the upper part of the medial infraclavicular space, where you can see the cephalic vein, and deep to it, you can see the three cords. Now, where can this be useful? Now, in some situations when you are not able to visualize the cords in the costoclavicular space, you can use this as a surrogate marker, where you can now identify the three cords here. And if you now dynamically scan more distally, you can track the individual cords. If you focus on one cord at a time, you can then track them more distally and get a clear visualization of the anatomy. So now this is the target ultrasound window, where we are looking at the cords of the brachial plexus deep to the pec major and the subclavius muscle, and superficial to the serratus anterior muscle here. This is your serratus anterior muscle overlying the second rib, and the three cords that are clustered together lateral to the first part of the axillary artery in the costoclavicular space. As we referred to before in our previous webinar, that there is a collagen tissue, the circumnurium of the brachial plexus, that actually surrounds the cords of the brachial plexus. And indeed, there is also a septum that becomes more visible with an anterior and a posterior compartment once you inject the local anesthetic in most cases. So this is how the anatomy is laid out when you look at the relationship of the cords from the costoclavicular space to the lateral sagittal infraclavicular space. You can see here how the relationship of the three cords remain quite consistent, although there is these three cords, they rotate into their respective position in relation to the second part of the axillary artery. So if you remember this anatomical relationship and you identify the cord at one level, you can track them back and forth. So dynamically scanning these cords and to look at their relationship to one another can go a long way in improving not only your knowledge, but sometimes identifying anatomical variations relating to that. This is also just to show you how the anatomical relationship of these chords change as you go from the costoclavicular space to the lateral sagittal. And it's not surprising that when you perform an injection in the costoclavicular space, it's much faster in onset and it's much more denser when you use low volumes of local anesthetic. And this is the basis of some of our work that I will present in a short while. Now, while the costoclavicular anatomy of the brachial plexus is quite consistent, a word of caution: you may often find a vessel that often crosses across this costoclavicular space in between the chords. As you can see here, this is indeed a low takeoff of the dorsal scapular artery that usually comes out from the subclavian artery. But I'm told by my good anatomical professor, Professor Morigal, that this is indeed could be a low takeoff of the dorsal scapular artery that comes off from the lateral aspect of the axillary artery and lying deep to the lateral and between the lateral and the medial cord. So with this anatomical and sonoanatomical information, let's see how we do a costoclavicular brachial plexus block. Again, you do a transverse scan, identify the chords of the brachial plexus at the costoclavicular space. So this is lateral, and that would be medial. So this is the head end of the patient. You can see an assistant is helping me inject. We also have a pressure transducer here, injection pressure monitor. This was because we were using it in the early parts of our study because we were injecting in a very compact neural space. The aim is to guide your needle from a lateral to medial direction and then hydrodissect your way through between the lateral and the posterior cord and place the injection somewhere at the center of the nerve cluster. As you can see here, the needle has been inserted and is positioned in the center, and the local anesthetic, after the local anesthetic, you can see 20 ml of local anesthetic has created an ocean of spread of these 2 to 3 chords of the brachial plexus, culminating in a very rapid onset of sensory motor blockade of the upper extremity. Again, this is a sequence of image to show you how you would visualize the needle. So therefore, when you do a costoclavicular brachial plexus block, it is imperative, and I say it is imperative, that you continue to see the subclavius muscle. Because if you don't see the subclavius muscle, then that's not the costoclavicular space. It's more distal, and it's in the medial infraclavicular fossa. And you can see here, once you inject the local anesthetic, it spreads quite extensively to the 3 chords. Okay, so now when you talk about brachial plexus today, we often talk about extrafascial, subfascial, and we discussed at length with Professor Bodzat and Professor Reina in the previous webinar as to how subfascial injections and what these circumneural injections, circumneural sheath is. You can see here, although it is very difficult to define the circumneural sheath before the injection, but you can see here, even with this high definition ultrasound, when you insert the needle, it's coming from a lateral to medial direction. As soon as you think you have gone through the subclavius muscle, use some normal saline to hydrodissect this area. You will see here as you inject the saline. If you are extrafascial, then you will often see that the chords are usually pushed away by the injectate. However, if you are subfascial, you will see separation of the chords, and you will see separation of the individual chords, which you may be able to appreciate in the next slide here. As you see, we are now at the center, and if you inject here, then you can see that the lateral cord is now separating from the posterior cord, and the medial cord is more deeper. Now, if you are using nerve stimulation, then use D5 water, dextrose 5%, and you will see the same effect. You can see now. So inherently, the costoclavicular block is a subfascial injection because it is now deep to the circumneural sheath surrounding the brachial plexus at this level. You can see here, you can see a sausage-like appearance of the distended the brachial plexus elements at the costoclavicular space. This is something we have demonstrated at length in our recent work in regional anesthesia pain medicine. You can see here in this another patient, you can see how clearly you can see the distension of the circumneural sheath. You can also see that the circumneural sheath not only surrounds the cords, but also it is an all-inclusive neurovascular sheath. As you can see again here, it is also encompasses part of the axillary artery and the vein. And it also has a septum, you can see, that goes through the circumneural sheath here, so that the lateral cord is usually in an anterior compartment, and the medial and the posterior cord are in a posterior compartment. So this is a septum that we discussed about in our previous webinar. So the septum is a structure that you will not see before the injection, but once you perform the local anesthetic injection, I believe that it causes the matrix of connective tissue that lie between these cords to congregate or aggregate in such a way that it produces the septum. And this septum is actually a fibrofatty collagenous septum that is within this circumneural sheath. Histologically, you can see here, there's a lot of collagen fibers that surround the cords at this level. And once you perform the injection at the center, the collagen fibers and fat all come together as the local anesthetic spreads, and this probably produces that septal effect that you see here. This is at the second part, as you can see the pec minor, and you can see here, this is a very clear depiction of the anterior compartment and a posterior compartment with the medial and the posterior cord in this case, and some branches are coming off the lateral cord. So there are two compartments now we are familiar with, the anterior and the posterior compartment with the septum. And the septum actually comes off the axillary artery, while the circumneural sheath is a all-encompassing neurovascular sheath. So what happens if you perform a costoclavicular brachial plexus block with 0.5% ropivacaine 20 mLs? This is what we did in our initial first study. We found, you can see here, that this is loss of sensation to cold in the y-axis here, and you can see in the x-axis is the time. So within 30 minutes, you can see there's a rapid decline in sensory sensation to cold in all the distributions of the median, ulnar, radial, and musculocutaneous nerve. And there's also a slower but rapid decline in motor function, so much so that within 30 minutes, they're all almost ready for surgery. We also did a randomized control trial looking at the lateral and the costoclavicular brachial plexus block. So the blue represents the lateral sagittal infraclavicular, and the yellow represents the costoclavicular brachial plexus block. When we look at the loss of sensation to cold, the sensory scores were significantly lower in the costoclavicular at all time points during this study period. When we looked at our primary outcome variable, which was the time to readiness for surgery, this is a criteria that we frequently use in our clinical practice, say that when your sensation is less than 30 and your patient exhibits some degree of motor weakness, then that patient is ready to be handed over to the surgeon, because by the time they finish their preps and they finish their draping and talking, then patients, the blocks are usually ready. So you can see here that time to readiness for surgery was almost half that in the lateral sagittal infra, and was highly significant. However, there are also studies from other research groups documenting that there are no differences in sensory motor blockade or other criteria when you compare infraclavicular, lateral sagittal to costoclavicular. However, I must warn you that there are differences in the different studies. Although this group demonstrated similar onset times, the differences may be related to the study was conducted in Canada, so they have larger body build. They have used much larger volumes of local anesthetic, 35 ml versus 25 ml, and they use drugs like lidocaine, which have a very rapid onset of block. So irrespective of whatever technique you use of lidocaine may sometimes circumvent the usefulness of one technique over another. And different outcome criteria of sensory motor block assessments were used. And I believe to expect complete sensory motor loss, in any clinical situation is probably a little too stringent in terms of when you're looking at it in clinical practice. The same group also have demonstrated that the ED95, or the minimum volume requirement, local anesthetic volume requirement, is 35 ml, 34 ml, and they seem to use 35 ml for almost all their blocks. So I think in this day when we are using ultrasonography and we are using smaller volumes of local anesthetic, this would be an excessive volume in my clinical practice. In our group of patients in Hong Kong, we have demonstrated that 21 mils is the ED95 using a similar methodology. We found the MEV90 of ropivacaine 0.5% as 25. This is an agreement with the more recent study in anesthesiology by this group, by Dr. Keolani group et al., and they have demonstrated a ED95 of 19 mils. So therefore, in clinical practice, we don't use more than 25 cc's. Now, you don't need 25, but if you want a much more rapid onset and a much more denser block of a longer duration, then 25 mil is quite safe for most patients. So this is why we use 25 mils in our clinical practice. Also, this is a study that Dr. Shiva Shanmugam from Pondicherry in India did, and I collaborate with them looking at ipsilateral hemidiaphragmatic paresis following supraclavicular and a costoclavicular block. We found that when you perform subfascial supraclavicular block compared to the subfascial costoclavicular brachial plexus block, there was a significantly lower incidence of hemidiaphragmatic paresis. Well, it was 45% in the supraclavicular block. It only affected one patient, i.e., 5% in the costoclavicular block. So therefore, it is indeed more phrenic nerve sparing in terms of diaphragmatic paresis. Also, although there were decrements in the hemidiaphragmatic diaphragmatic excursion, there were also changes in peak expiratory flow rates before and after the block, but none of them was statistically significant, and none of these patients in this cohort exhibited any clinical signs of decompensation. But one must remember that these are patients with no preoperative respiratory disability. Also, a recent cadaver study by Dr. Koyala Mundi and the group from Arizona in the United States in a cadaver study demonstrated that when you perform a costoclavicular brachial plexus block, it not only spreads cranially and caudally to affect even up to some of the the ventral ramus of C7, C8, and T1, but also it spreads quite extensively distally. One of the things I think some folks that are not familiar with the research may say that, oh, when there is coloring, there is anesthesia. Unfortunately, coloring does not mean anesthesia or analgesia. It just means that there is an anatomical pathway for spread of the drug or the injectate to that target level. So you can see here in this 5 dissections that they did, you can see that after costoclavicular block, you can spread all the way up to C7, T1, ventral ramus. It affects all the 3 trunks. This is good news. This is pretty much like the SeTB, because we in SeTB, we are trying to selectively identify these trunks and block them. But here you're performing a costoclavicular block and you're still able to stain the 3 nerves. I'm not saying block the 3 trunks, because blocking these trunks is much more than meets the eye than just staining these 3 trunks. But nevertheless, it affects all the 3 lateral and medial and posterior cords, so produces very rapid onset of effect. Interestingly, it also affects the suprascapular nerve, and therefore, in recent time, is also being used as a non-inferior analgesic technique for shoulder surgery. And given that it also affects the lateral cord, the posterior cord, and some of the nerves, other nerves that supply the shoulder joint with the suprascapular nerve, it's not surprising that it produces non-inferior analgesia, but it has a greater hemidiaphragmatic paresis or say phrenic nerve palsy sparing effect. You can also, so what do you do if you are unable to abduct the arm in these patients? A medial approach or a medial variant has been described, and this does not require the arm to be abducted. All you then do is to insert the needle from a medial to lateral direction and Dr. Salablanche and the group from Barcelona also described that this technique may have advantage because now the needle is not being directed towards the pleura. It's actually going away from the pleura more towards the rib. So I think for novices, this may also be another way to perform the block, as long as you remember that you perform the block between the lateral cord and the axillary artery, and then perform an injection deeper, closer to the medial cord. Would you do a single or a multiple injection? There are now some research data available, randomized controlled trials showing that a single injection, when you compare a single injection to a double injection technique, a double injection technique has a much faster onset of sensory block. Sensory onset and total anesthesia related times are shorter here. In this case, you have a shorter onset. This group, again, also I think from mainland China, have demonstrated that a triple injection as opposed to a single injection, a triple injection, identifying the individual cause and injection may be desirable when you want earlier onset of anesthesia in the 3 nerves. As you can see here, the triple injection achieve a higher rate of complete sensory motor blockade at 30 minutes. So what about catheter? This is the final aspect about this technique that I'm going to discuss before we end. So we've done some preliminary experience with this. As I said, placing a catheter at the center of the cluster is a subfascial placement. And being able to place it right at the center of the cluster is, again, probably beneficial because now your local anesthetic can spread to all the 3 cords. So as you can see here, the patient is lying supine with the arm abducted. We do a transverse scan with a high-frequency linear transducer, sterile aseptic precautions, and we use a transparent drape. So this allows you to not only see the anatomy, but also see if you're looking for any motor response. Somebody asked, where do you source these plastic drapes? Unfortunately, I don't know where you can get them in Indonesia, sir. But I'm sure if you look around your providers in your country, you will find somebody who will have these drapes for you. And as you see, it can be quite useful when you're doing these blocks. So we use a catheter over needle, which is there are a number of them in the market today. This is the E-cath that we are using here. The reason I use these catheters because is that you insert the needle to the point where you want to leave the catheter, because there is no need to thread the catheter. Besides, because the catheter is larger than the needle, there's often no back leakage through the skin puncture hole. As you can see here, you can very effectively secure the catheter because it has another introducer inside, and it almost becomes unkinkable and unobstructable because of the anatomic of the engineering involved in the catheter design. You can see here the needle is introduced from a lateral to medial. Once the needle tip has been placed in its site and we've injected a bolus of dextrose or the local anesthetic, we just remove the stylet and the catheter obturator is introduced inside, and then with an extension, the catheter is secured in place. And you can see here, the catheter tip can be seen, in fact, overlying the serratus anterior muscle. In fact, the pool of local anesthetic has lifted the cords of the brachial plexus. It's quite easy to secure it. And one of the advantages we find, although again, the experience is quite lacking all around, there are not many published data, but in clinical practice, I now rarely use more than 5 or 6 mils of 0.1 to 5% infusion through these catheters in the post-operative period, and they seem to provide quite effective analgesia for post-operative pain relief. Again, you can also place catheters, and this is a catheter that we often use also. This is a silver stem catheter from VII. They're also very useful, very echogenic, and can be placed through the needle. But this is a catheter through needle, like your Tuhi needle, etc. And they can also be used to stimulate the neural elements. So it gives you a dual kind of function and can be quite useful when you come to respect to this. So concluding remarks after such a long-winded presentation is that the anatomy of the brachial plexus is very unique when it comes to brachial plexus block. I've also demonstrated to you that the zona anatomy of the brachial plexus of the cords of the costoclavicular is very unique, very consistent, and you can indeed place a needle very effectively at the center of the cluster within the costoclavicular space. An injection of 20 to 25 mils of local anesthetic, which is the ED95, produces very rapid onset of sensory motor blockade. It produces sensory blockade readiness for surgery that much faster than a lateral sagittal infraclavicular brachial plexus block. You can understand it because the anatomical features allow you to produce very rapid onset of block with lower volumes. However, if you use large volumes of local anesthetic, as the literature suggests, there will be no difference. So therefore, if you have a patient who is probably frail, elderly, and you don't want them to be at the risk of local anesthetic systemic toxicity, then maybe costoclavicular, because it provides good efficacy with low volumes, may again be desirable. There is definitely a potential for pleural puncture, but if you consider the anatomy and you have the appropriate dexterity, then pleural puncture is not an issue. Ipsilateral hemidiaphragmatic paresthesia is less than supraclavicular and infraclavicular brachial plexus, interscalene brachial plexus block. And today, it's also being used for a shoulder surgery. So I think when you look at costoclavicular block, as far as I'm concerned, it looks like this big fish. You can see the sailfish that we caught off the coast in Malaysia. So if you go on an adventure in your life and you find, once in a while, you find some good things. I think in my journey in regional anesthesia, I think costoclavicular block has been one of those that I can count as a good find, because I think this is a block that is here to stay, and I'm sure long before or long after I've gone from this field of regional anesthesia, it will still be knocking on the doors of many regional anesthesia block rooms and operating rooms. So with these few words, ladies and gentlemen, thank you for your attention. So after this fairly long session, I hope you've been able to assimilate all that we've said. So we're now going to have a short break of 15 minutes where you can go and have, as I always say, have your favorite beverage. And then we will come back together, and then we'll have maybe a 15-20 minutes of discussion and after the live demonstration. So before we go on this break, if you have any questions, then we are happy to answer them now. And I think Rossini has been our moderator, and she will be collating these questions. Rossini, are there any questions for Ke-Vin and me?
There are several questions. So you want me to ask them now, right?
Yeah.
Okay, so we've got Dr. Manfredi and Tio Cole asking whether or not it's safe to navigate the needle in plane from lateral to medial in interscalene block, and whether or not there's a concern of injury to the dorsal scapular nerve or the long thoracic nerve, and whether or not there will be the need for nerve stimulator to avoid the injury to these nerves when performing such technique.
Are you going to answer that, Ke-Vin, or I can do that? Okay, maybe I answer that question. As Dr. Chang has illustrated and demonstrated to you how you can identify the dorsal scapular and the long thoracic nerve. Yes, the dorsal scapular nerve certainly comes in the line of fire when you are doing an interscalene block at the level of the ventral rama of C5 and C6. Usually, as Ke-Vin has very well illustrated, it usually lies in an intermuscular tunnel kind of thing, and is often seen as an elongated hyperechogenic line. So when you are introducing a needle through the, at least certainly when I'm introducing my needle, it is always a concern. But when you introduce your needle, try and avoid these white hyperechogenic areas within the interscalene, within the scalenus medius muscle, and it's a reported complication. But whether we should be using nerve stimulation in all patients, I certainly don't do that. And there are some literature in the data saying that when you introduce your needle in an in-plane, about 40 or 50% of the time you may encounter the dorsal scapular nerve. While this may be true, but I think if you are familiar with, and after today, you should be familiar with how to identify the C5 and 6 ventrorama, and you can also see how the dorsal scapular nerve offshoots from the C5 ventroramus to come off it into the scalenus medius and then exit at the posterior part. So if you have a good understanding of the anatomy, I think it is possible to circumvent inadvertent injury to these nerves. Do you have anything to add, Ke-Vin?
Oh, okay. In my opinion, if the doctor performed the interscalene block, I think the first one that could be injured is the long thoracic nerve, because the dorsal scapular nerve is location is quite cranial. So if if you put your transducer in the horizontal plane, actually at that level, most of the dorsal scapular nerve has already exit through the posterior aspect of middle scalene. The reason why you can see in my video, we can clearly see the dorsal scapular nerve is because I did not place the transducer in the horizontal plane. Actually, I place it in oblique plane. So at the posterior aspect of transducer is more cranial than the anterior aspect. So that's why we can clearly identify the dorsal scapular nerve existing from the middle scalene. So in this case, if you just use the regular way to scan the brachial plexus, I think if you want to injure the dorsal scapular nerve, the most likely scenario is when you perform the C5 or C6 selective nerve block, because the dorsal scapular nerve is just posterior to the nerve root. Thank you.
Yeah, I think what you say is very right. It's the two nerves are often not clearly visualized because they are anisotropic. You have to tilt the probe in a slightly more oblique orientation to be able to visualize it. And in some cases where you see it is probably what you are doing inadvertently, that you are at a more oblique plane than the typical transverse oblique scan that we do for interscalene block. So try that next time. You may be able to visualize the dorsal scapula and in particular the long thoracic nerve more often. Okay.
Yep, thank you. Another question from Dr. Wu from Guizhou. Dr. Wu would like to ask whether you have seen any interesting anatomical variations during your scanning.
I think to answer your question, anatomical variations are more common than you can even think about. So, in fact, in anatomical literature, if you look at any structure, there are more than 150 or more than 100 anatomical variations of every single anatomical structure. So, how frequently they occur? It is very, very frequent. So, to expect something to be there always is probably a bit naive. So, therefore, again, your question is very valid, but for me to be able to see all these anatomical variations in a single career is probably a little bit too much to expect. So I often see them, and some of them I've already shared with you, but I don't see them on a very regular basis. And this is, again, the main reason why I often say that you must have a systematic approach to the scan. If you don't have a systematic approach, you're never going to see a variation, because you don't have an idea what you are looking at. You're only expecting the final outcome of the anatomy, and that anatomy may not be really what you are expecting.
Okay. Then we have Dr. Koki asking whether neurolysis of the individual nerves of dorsoscapular nerve, long thoracic nerve, or suprascapular nerve can be done safely with alcohol or radio frequency ablation for pain management?
Ke-Vin, that is your
Okay.
area. You can.
Yeah, I think the question is very interesting, but I'm thinking in what kind of scenario where you do the neurolysis for the suprascapular nerve? Because for the long thoracic nerve, dorsoscapular nerve, and the suprascapular, they are mixed nerves. So if you perform the neurolysis, it's going to affect the motor function. So I think we can consider to use pulse radial frequency ablation for pain management, but if you want to use neurolysis, I don't think I can not think of any clinical situation that I would do that. Yeah, of course, under ultrasound, we can clearly see it. So if you want to selectively do some intervention, I think it's feasible. Thank you.
Also, do remember that there are anatomical data now showing that when you do anterior suprascapular nerve block, the local anesthetic or the injectate can actually spread towards the superior trunk and even more proximally. So any neurolytic agent distal injection may still get its way to where you really don't want it to go, unless you are doing a more distal block like at the supraspinatus area in the relation to the scapula. So it's just a comment.
Mm-hmm. Thank you. Another question from Dr. Matthew Kumar asking you how much volume do you usually give for medial infraclavicular fossa block?
Costoclavicular brachial plexus, as I told you, we use maximum 25 mils. And this is all you would need for any proximal infraclavicular brachial plexus block, whether you are doing it at the medial or at the costoclavicular brachial plexus area. 25 mils of appropriate local anesthetic surgical concentration would be good enough.
Okay, there are several questions from the chat box and not from the Q&A box that might be a bit interesting. So for costoclavicular block, do you do a separate supraclavicular block if you are doing it for an anesthesia for shoulder surgery?
That's a good question. In fact, there are literature today now showing that costoclavicular brachial plexus block produces non-inferior analgesia to an interscalene brachial plexus block for shoulder surgery, postoperative analgesia after shoulder surgery. So if you look at how could that happen? I mean, costoclavicular block. But if you look at the innervation of the shoulder joint and the anatomical data that we have, saying that when you perform a costoclavicular block, the drug can also spread to the suprascapular nerve, towards the supraclavicular fossa. It affects the posterior cord, where it supplies the upper subscapular, lower subscapular nerves. You have your lateral cord, which contributes to it. So there are many neural elements within this block dynamics that actually innervate the shoulder joint. So it's not surprising that costoclavicular block can provide non-inferior analgesia to interscalene block. But the important thing is that this non-inferior analgesia is in conjunction with a multimodal balanced analgesic approach that is standard practice today, which is good because it produces significantly lower incidence of hemidiaphragmatic paresis. Now, in the study I quoted, in the study we report, it's 5%, but there are also studies showing that when you look at hemidiaphragmatic paresis after costoclavicular block, it is indeed 0. But maybe they didn't, maybe they were lucky. So I think it is low, but it is probably 5% is a reasonable estimate. It's so therefore in these situations you have to make a educated decision whether to use this or not.
Okay, there's another similar question from Dr. Sammer, but this time they're asking whether or not you would also add a superficial cervical plexus block to costoclavicular block for shoulder surgery.
I don't do shoulder surgery purely with regional anesthesia. But even if you are doing it for analgesia, I don't think a superficial cervical plexus block would be of much added benefit, although there are some components of the shoulder that are innervated by the supraclavicular nerves. So I think if I were to do it in my patient, I would not do a superficial cervical plexus block.
Mm-hmm. Okay. There's also a question from Dr. Hughes asking whether or not you have any experience with performing costoclavicular block in children and whether or not there are any age limitation for these blocks.
Yes, I have experience. I have done a few. I wouldn't say a lot of them because we don't see many of these patients coming with hand trauma that require surgery, like, that requires extensive post-op pain relief. I would say that your age limit is how brave you are. And I think in these smaller age groups, when you want to put a needle in such a location, I think you have to be a little careful because you have to justify why you are doing that block in that location when there may be safer alternatives and in a very tender age group. So I would leave the question back to you. Is that the question arose in your mind? You have to justify why you want to do it in very young children. I don't have a need to do it in very young children.
Okay. So question from Dr. Jimmy Wang. Since that costoclavicular block is a subfascial block, what do you expect the injection pressure to be like? And is it reliable to feel it without a pressure meter?
Well, that's an exceptionally good question. It's a difficult question to answer, but I can tell you by practice, by experience, is that when we use the injection pressure monitors, they really didn't help a lot. And because your needle tip could be against the connective tissue barrier, if you may, or it could be against the muscle, or it could be against the connective tissue layer. Without being inside the nerve, you could still have a relatively high injection pressure. You could see that thing would shoot up. And this has also been shown with respect to interscalene blocks and other areas of brachial plexus blockade. However, when you inject with the hand, your syringe, there are also data saying that using your hands to estimate the pressure at the tip of the needle is very, very inaccurate. So I think you have to use common sense. When you use ultrasound, we are not relying on only the injection pressure. You're looking at the ultrasound, you're looking at the injectate, how it spreads in relation to the area that you have placed your needle. So if you inject and you don't see any injectate spread, that usually intravascular unless proven otherwise. That's what I teach my fellows and residents. Secondly, when you inject and you see a good spread, that means it is extraneural, whatever. If it inadvertently, unfortunately, if you place the needle in the nerve and you inject a small volume and you see swelling up of the nerve, then you must abort that injection. Hopefully, no untoward side effects, neurological sequelae will happen, but you got to monitor that patient. It's when you inject large volumes of local anesthetic into a nerve that it may cause harmful effects that may be devastating in the postoperative period. So I think you mustn't rely on one single monitor or the injection pressure because it's been shown to be very non-specific. It can happen, high pressures can occur because of many different reasons.
Okay, thank you. I think that's pretty much the question from the Q&A box, but I have a question myself from Professor Karmakar.
Okay.
So you mentioned that you usually perform selective trunk blocks for surgeries up to the entire upper limb. So I recently had a surgery for mid-humeral fracture, which the surgeon performed an open reduction internal fixation. But I noticed that they actually did their incision from the medial side of the upper arm. So since that area is innervated by the T2 dermatome instead. I wonder if you have any experience with such surgeries and whether or not selective trunk-blocks were adequate to perform anesthesia in these procedures.
I would say that's an unusual situation where the surgeon is approaching it from the medial side of the axilla or the arm. Usually these surgical procedures are done placing a guide wire into the humerus, and then they bypass the fracture site, and then through that guide wire they place an intramedullary nail. The interlocking nails are then placed at the shoulder, as I showed you in the picture, and then a distal interlocking nail usually goes in at just above the condyle, so in the lower part of the humerus. So very rarely or unusually they go through the medial side of the arm. So if you have one that they're going to the medial side of the arm, then I think you're at a loss here. Your SeTB or supraclavicular block or whatever block you do is not going to be adequate for your surgical anesthesia. You might have to supplement it with a intercostobrachial nerve, brachial nerve at the level of the conjoint tendon, latissimus dorsi, etc.
Okay. There's also a relevant questions that's related to mine. So Dr. Olsen Wu is asking whether Dr. Karmakar and Dr. Chang has suggestion on a reliable way to block the intercostobrachial nerve proximal to the axilla.
There you go, Dr. Chang.
Okay. Because I'm a PM doctor, so I have no experience of nerve block over this region. But as far as I know, actually the intercostobrachial nerve has anastomosis with the nerve anterior to it. For example, the medial brachial cutaneous nerve, especially if you trace the nerve to the more distal part. So in my opinion, I think, we can find because cutaneous nerve has a pattern of, it's a small nerve fascicle surrounded by some fat. So you can use that pattern to recognize this is the cutaneous nerve. But if you want to clearly validate this is the intercostobrachial cutaneous nerve, I think you need to use a nerve stimulation. Otherwise, another way is, okay, you find all the cutaneous nerve at the fascial plane and then you block them all. Yeah, it's my opinion.
Yeah, I think what you say, Ke-Vin, is right. If especially the question says above the axilla, then you have to come through the upper part from the pec, from the more from the serratus plane, kind of from an approach from a lateral. And such technique has been described in the literature, where they inject it superficial to the serratus anterior muscle. So you're injecting it in a plane, using a larger volume of local anesthetic. Also, what Ke-Vin mentions is very true, because in some of our ongoing studies, we often find that without an intercostobrachial nerve, you will find that in about 30-40% of individuals, you find that the area innervated by the intercostal brachial nerve is sometimes patients will report loss of sensation in that area. And I think this is because of the communication with the medial brachial cutaneous nerves and some of the other cutaneous nerves in that area. So with the same analogy, you could do an intercostobrachial nerve, but still your patient may still report tourniquet pain or pain related to that area, because this area is a watershed zone. So sometimes a subcutaneous injection just deep to the subcutaneous tissue and superficial to the deep fascia in the axilla actually takes out most of these medial brachial cutaneous nerves, and they are quite effective when it comes to tourniquet tolerance in most of these patients.
Okay, thank you. I think that's pretty much the questions that we have from the audience.
Okay, I think I'm sure you will have many more questions, but we need to have a little time off here. So I take this opportunity to thank Ke-Vin. You've been a great champion. Keep up the good work, and keep supporting the ISSPS. And I'm sure we will see you again in the near future.
Okay,
For
thank
those of you who are truly interested in small nerves, musculoskeletal imaging, look up Dr. Chang in Google and you will be surprised. Not surprised, I would say. You'll be amazed to see all the lists of publication that he has done in this area. Thank you again, Ke-Vin. So for the rest of you in the audience, we'll have a 15-minute break. So it's 8 p.m. in our time. So 15 minutes later, we will come back to you all with a live demonstration of some of what I talked about with the SUD, the SeTB, and the Costoclavicular, and some of the medial infraclavicular anatomy in a systematic way. We will do a live demonstration of this. Okay, thank you for now and see you soon. Okay, welcome back. In this short demonstration, I'm going to do the sequential ultrasound imaging technique. We will try to put this into practice as to how you can identify the individual elements of the brachial plexus. We will then also use the sequence I showed you to perform a scan for the costoclavicular area and the medial infraclavicular fossa. If time permits, we will go into the axilla, but otherwise I think axilla most people are quite familiar with, so we will restrict ourselves maybe to the above the neck supraclavicular fossa and maybe the medial infraclavicular fossa. For this demonstration, we are going to be using the VII Labat machine. You can see here. This is their card-based system. We're going to use a high-frequency linear transducer. This is from 15 to 4 megahertz. We're going to optimize it. So I'd like you to, for those of you who are maybe newcomers or novices and you want to know what makes up a good picture, just try and focus on what I'm trying to achieve here. Daniel here is from VII. He is going to help us with optimizing the system. But since we are live, so you should be able to hear what I'm asking Daniel to, because it's a little bit further away. So we're going to find myself nicely comfortable here. So this is okay. So for this demonstration, the orientation marker, which is the red area over there to the top of the image, is going to be the top left of the ultrasound image. No, you need to the pointer. The top left of the image is going to be the lateral, and to the right is going to be medial. Okay, can I have some gel here, please? So we're going to use the gel. Now this is optimized for 15 to 4 megahertz, high frequency linear transducer. So can you increase the depth, the touch for me, please, Daniel? Okay, that's fine. Okay, first I'm going to optimize the image for the supraclavicular fossa. I'm looking for the subclavian artery. You can see the subclavian artery lying on top of the first rib, very close to the pleural surface. You can see there. Can you reduce the depth now? Okay. Is it possible to zoom a little bit? Maybe you can pinch it. Yeah. That's it. There we go. Okay. Now, what's the map? Can you change the map here a little bit? Frame map. Change it a little. Okay, that looks all right. Oh, okay. Right. Okay. Right. So this is I think I'm quite satisfied with this. And you can see here, we're going to look for the subclavian artery, and they are the elements of the brachial plexus that are located posterior and lateral to it here. Yes. Okay, so I'm going to now sweep the transducer in a cranial direction, like so. And then once we get to C5, I'm going to sweep it back again. Okay, and I will show you all the elements that we come across along the way. So that's the first rib that you can see the arrow there. Okay, now I'm going to go cranially and look for the C7 posterior tubercle. There we go. It just now appears in the ultrasound image here. You can see the C7 transverse process, the posterior tubercle. Anterior to that is the ventral ramus of C7. You can see the C6 on top of that. Yeah, you can see the C6 has actually two components to it here. Yeah, and this is the C6 ventral ramus, because you can see the C6 got to anterior and a posterior tubercle, and the C6 ventral ramus just emerges from it. Okay, you can see a big intramuscular bridge between the C6 and C7 ventral ramus. You can see the ventral ramus here. That is the big muscular bridge. Okay, and then if we go further up from C6, you can see the much smaller C5 ventral ramus here. Yeah, this is the much smaller C5 ventral ramus. Okay, since we are looking at the brachial plexus, let's now look in a reverse direction. We're going to scan distally. You can see the C5 over there. Focus on one element at a time. You can see the C6 is just now appearing. Okay, the C5 and C6 are going to fuse together to form a large superior trunk there. And then, as I mentioned, the neural stack is now visible here. You can see the superior trunk, the middle trunk here, which is the C7 now continues as the middle trunk, and the C8 ventral ramus is located on top of the T1 transverse process and first rib complex. Okay, so that is your the neural stack. Okay, so let me just put it on number 4. Number 4, F4. Better? So you can see here, that's the neural stack that we are referring to. Now let's now focus on the superior trunk, okay? Now look at the superior trunk. It's quite superficial, less than a centimeter from the skin. And then you can see it's between the scalenus anterior, which is to your right, and the scalenus medius muscle, which is to your left. And now let's look at the superior trunk. You can see the superior trunk. If I go slightly caudate, I'm sliding it slightly caudate, you can see it is now dividing. You can see the suprascapular nerve has just emerged from it. Okay, that's the suprascapular nerve. Oh, this looks like a familiar picture from my presentation, right? Okay, so you can see here, they have a trifurcated, you can suprascapular nerve, the posterior division, and the anterior division of the superior trunk. So this is indeed the spa of the brachial plexus that you can see here in this individual, in this volunteer here. I go back again. You can see the C5 and C6. The C5, C6 fuse to form the superior trunk. Superior trunk is now trifurcating into the S, P, and A, and then deep to the superior trunk. I already showed you the middle trunk and the C8. Now let's try and see if we can see the inferior trunk. So now we need to increase the depth a little bit. Okay, because we want to see where the T1. Okay, now if you see here, this is our neural stack of the 3 nerves, superior, middle, and inferior trunk. I'm going to sweep the transducer in a caudal direction, like so, okay, as you can see here, as it increased the angle till it almost coronal in some respect. So it's a coronal oblique scan in that respect. So I'm going to see you here, and then watch the C8. The T1 is going to come from underneath. There, you see the T1 has just appeared there, see? To your left. Yeah, there's the T1. Okay, I'm going to scan back and forth. This is going backwards towards the neural stack, going forward towards the supraclavicular fossa. You can now see the T1 has just emerged. There it is. This is the T1. It's going to go around. You can see the T1 very clearly now. It's going to go swing around the on top of the first rib to form the inferior trunk. Actually, you can see the C8 and T1 separate here, and they just form to form the inferior trunk here. So the inferior trunk is located over there. So now you can now see which is the suprascapular nerve. Look at the posterior and the anterior divisions of the suprascapular nerve. Okay, we are going to follow it down. You see the suprascapular nerve has gone laterally. Now the 2 top elements are indeed the posterior and the anterior division. Okay, I already showed you where the inferior trunk is located. That one. So all that is left is the middle trunk here in the middle. This is the middle trunk, which is showing 2 elements, maybe just dividing into its posterior, which is where the arrow is, and the anterior will be more medial to it. So I think the bunch of grapes is actually all been unraveled if you do a proper scan from a distal to proximal. Okay, we start again. This is the supraclavicular fossa. You can see the subclavian artery. with the bunch of grapes that we have already unraveled what they are. And I'm just going to scan, sweep upwards till we now see the posterior tubercle of the C7. That's the posterior tubercle of C7. If you put the Doppler there for me, please. Yeah, you can see here, move the box up a little bit. Yeah, okay, to your left. Don't want the jugular vein, want the smaller vessel. Okay, you can see the, yeah, you can see the vertebral artery and the vein, which are just adjacent to the C7 ventral ramus. Okay, that's the vertebral artery and the vein that are next to it. Okay, let's go B mode, please. Okay, now once we've seen the C7, I'm going to go backwards towards the C6. You can see the C6 with the prominent anterior and posterior tubercle, the C5. In fact, you can go even further, you will see the C4. This is the C4 here. So C4, this is your C5, then your C6 will appear, and that's the upper trunk being formed over there. That's your upper trunk, middle trunk, and C8 stack. So as I mentioned during my presentation, you can see here that the C8 is very consistently located on top of this T1 transverse process first rib complex. So you can see that once you see this C8, the structure that you see on top of that is the middle trunk, and the structure that you see on top of that is the superior trunk. So if you are doing selective trunk block, then this is our first target window where we are looking for the superior trunk, the middle trunk for our injection, where we deposit 7 mils close to the superior trunk in a periplexus location. Can you put the arrow there, please? To the left. Yeah, there. In this periplexus location for the superior trunk. And then you withdraw and redirect the needle towards the middle trunk, again within the interscaling groove. By now, the groove would already be distended, and you'll also see some spread of local to the C8. And then we come back, and now you can see how the T1 is coming out over there. That's the T1, and it swings across, fuse with the C8 to form the inferior trunk at the corner pocket. So now, if we were doing a SeTB, then your this area would be already quite distended by the injections above, and therefore the aim should be only to deposit the local anesthetic adjacent to the inferior trunk. And I don't strictly go now straight for the corner pocket because it's distended. It's better to be more closer to the medial aspect of the artery than to the lateral aspect of the inferior trunk. Okay, so this is basically the scan here. Now let's see if we can see some of the major arteries that are located here in relation to the transverse cervical artery. There it is. It's very closely related to the superior trunk, as I mentioned. So if you put some Doppler there, you could see up. Okay, there you see here. This is one of the vessels here. This is the dorsal scapular artery. It's actually going from the subclavian, there you go, subclavian all the way through the neural elements, posterior part of the neural elements, and going away laterally. Okay, so this is your dorsal scapular artery. So sometimes, as I showed you in the anatomical variant, it could also take off a bit lower down at the costoclavicular space. So now if we go slightly more capillad, if we can see, you can see the transverse cervical artery over there in the middle of the scalenus anterior muscle, near the C6, the middle trunk. So need to line the patient. Is that on top of that? Yeah, yeah. So today I just can't show you where the transverse cervical artery is. But this is one artery that you need to find in your scanning routine before you perform this injection, because sometimes it's just where the arrow is. It's usually located on top of the scalenus anterior and the medius muscle. It could also bisect between the superior trunk and the middle trunk. Okay, so this is pretty much the upper part. It's quite simple. Start from the supraclavicular fossa and swing your way slowly upwards. It's a very simple, it's a very wristy action. So you just have to tilt your wrist upwards. Where is my, okay, so it is quite simple. You just have to use that sweeping motion. And if you use that sweeping motion, then you'll be able to identify most of these structures. From here, supraclavicular fossa, and then we bring away towards the C7 transverse process. Once you identify the posterior tubercle, it's easy. Then 7, you can see the C6 is bifid here. You can see the C6 is relatively large, and it's a bifid. So you can very easily mistake C5-6 as C5-6-7. Yeah, but it's actually C5-6-6. And then you can see the C5 is much smaller. It comes off through the C5 transverse process. 5 and 6 will fuse to form the superior trunk. So superior trunk blocks are a well-described technique now. It is used for shoulder surgery as a non-inferior analgesia, but more preservation of phrenic nerve function, as phrenic nerve sparing. Not totally, but certainly less phrenic nerve involvement. And then you can now see the middle trunk and the superior C8 here. This is the neural stack. And then if you go further down, you can see the T1 is now just emerging from underneath, and it will fuse to form the inferior trunk. Also note the suprascapular nerve. Anterior suprascapular nerve block is the well-defined technique today. So find the superior trunk, find the superior trunk, and then you can see its trifurcation. And as it goes laterally, below the omohyoid muscle, that's the omohyoid on top of it, yeah. You can see the, yeah, that's the, sorry. You can track it. That's the suprascapular nerve. And then you'll see the serratus anterior muscle overlying the rib, okay? So here is where the long thoracic nerve is located, as Ke-Vin showed us. You can see here. So the suprascapular nerve can be injected in this area. But remember that even an anterior suprascapular nerve block can affect your phrenic nerve, because it's not very far away from where the phrenic nerve is, although it is much farther away than the C5. But even an anterior suprascapular nerve block can affect the phrenic nerve in rare occasions. Okay, so this is about the upper part. So now I'm going to show you the costoclavicular space. Now keep it like this a little bit. Yeah. Put your arm. Okay, now I'm going to do a scan of the medial infraclavicular fossa so that we can identify the relevant anatomy. So again, here the orientation marker is the lateral. Okay, so you can see me. So this is lateral here. So this is going to be lateral. The image is going to be like so. So we'll start from the clavicle. We just put it on the clavicle. So you can see here, same structure, then I'm just going to slide it underneath it. And here my aim is to try and get a good view of the subclavius muscle. I can see there now, you can see the subclavius. Okay, you can see the pec major and the subclavius muscle there, yes. And you can increase the depth by 1 notch. Yeah, and you can see the the first part of the axillary artery is lying on top of the second rib. Okay, and the cords of the brachial plexus are clustered together lateral to it, you see there. Now, this is an angle at which I can now see the serratus anterior muscle very clearly, the anterior wall of the serratus one, anterior part of the serratus magnus here. You can see that when I can see the serratus anterior, the 3 cords are very clearly visualized. This is the lateral cord here, the medial cord just posterior to it, and then lateral to that is the posterior cord. Okay, so these are the 3 cords that are located there. A needle will come from a lateral to medial direction. And as I said, when you do a costoclavicular block, it is imperative to see the subclavius muscle. If you can see that the anatomy can be quite similar, slightly distally, which is the medial infraclavicular fossa. But now you can see here the cephalic vein comes in the way deep to the pectoralis major muscle and the deltoid. So you can see here, this is not the costoclavicular space, although they are quite contiguous in that respect. So always look for the subclavius, and the needle should be inserted from a lateral to medial. Although if you can't abduct the arm, as Dr. Salablanche and the group do, you may just put your arm here, please. Okay, we can just abduct the arm here. And now you see the anatomy has changed altogether. So it is not always easy to see the anatomy of the costoclavicular space with the arm abduct in the neutral position. See here? You can see that it's a little difficult to visualize them all. That's why I, for one, always prefer to keep the arm abducted at 90 degrees like so. But because we don't have a table, we just put the arm here. So here you can see, if I just start from the clavicle, I'm going to just slide it caudad. Okay. And now we can see the, can you reduce the overall gain a little bit? A bit too bright. You can see the pec major and the subclavius muscle. And then the cords of the brachial plexus are just lying lateral to it on top of the serratus anterior muscle. So with experience, you'll be able to define this much better. In some patients, it's much better seen than others. But important to remember that the aim is to hydrodissect your way into the center of the cluster. Once you understand the anatomical relations of the 3 cords, it becomes easier. And therefore, one, if you wish, if you're a beginner, I would suggest you use the nerve stimulator, because then you'll be able to define the individual cords. With the anatomical knowledge we have today, I don't think that is absolutely necessary. But if you want to develop your skills, then I think starting off with some nerve stimulation, and then as you get more confident in identifying these elements, then you probably don't need to do it on a daily basis. Okay, so if I go slightly more caudad, say the arm is abducted here, you can now see the cephalic vein. It's lying on top of the axillary artery here. Yeah, the axillary artery, cephalic vein, axillary artery. And lateral to that are the 3 cords of the brachial plexus. You can see here. Yeah, the lateral is always superficial. Yes, the medial is deeper, and the posterior is more lateral to that. Now let's see if I scan more distally. You can see here, this is almost coming towards the lateral sagittal infraclavicular fossa. Now let me go back again to this area. And then you see the 3 cords here. If I scan more distally, so this is like you're dynamically scanning it. If I just place the probe in this lateral sagittal fossa, I may not be able to identify the three chords very clearly at first glance. But if you know exactly what the three chords are, like from a more proximal location, now I know which is the posterior chord. I now know which is the lateral chord. So if I keep tracking it distally, keep it on top of the posterior chord, please, just to make it more lateral and chordal. Yeah. So you can see here that by the time we get to the lateral sagittal infraclavicular fossa, the posterior chord has come to about the 6 o'clock position, you know, over there, and the lateral chord is more laterally there, that area there, yeah, and then you can't really see the medial chord so clearly. But if you track the medial chord more medially, now we are going to put the marker on the medial chord, and we just focus on the medial chord. You can see I have seen it go across between the artery and the vein. See, you can see there it is now swinging across to go in between the artery and the vein. So there it is. Yes, that's the one. So it's lying between the artery and vein. So in this young man, it's usually 3 o'clock, 6 o'clock, 9 o'clock. So he has got the perfect anatomy. Okay, the locations of the three chords are in good position. Okay, good. Cool. Increase the depth from here. Okay, so that's pretty much about the lateral sagittal infraclavicular fossa. So now I'm going to show you the sagittal anatomy. If you understand that the cords of the brachial plexus are running like so from the neck, coming down the clavicle, and then into the axilla. So if you imagine this is the position of the neurovascular structures, and if you do a scan like so, relative to my finger, it is indeed an oblique scan to the neurovascular structures. Whereas if I pivot the caudal end of the probe, if I pivot the caudal end of the probe more medially, like so, that becomes and now at right angle to the cords, okay, relative to the arm. So sometimes when you perform these scans, try to think about the neural axis and try to align the probe at right angle to the axis rather than to the sagittal axis of the patient. Because if your beam is at right angle to the structure, you're more likely to see it at a better more clearly. So you may have to pivot the probe a little bit like I have done here to better visualize it. Okay, now let's see some of the other associated anatomy that we can see here. So now follow the axillary artery. We are seeing the cephalic vein. The clavicular head of the pectoralis major is on top. You don't see the pec minor, okay? So as I scan more distally, now the pec minor has just appeared here. See, yeah, the pec minor has appeared, okay? And then you can see some vessels in between the pec major and the pec minor. Can you put the Doppler? That's easier. Sensitivity, PRF. Yeah. So you can see that that's some of the pectoral branches of the thoracoacromial artery between the artery and between the pec major and the minor. They are more seeing like little, yeah. There. Okay. Now, if you just take the Doppler away, the next important structure that I think you should be able to identify in this axis is the thoracoacromial artery as it emerges from the axillary artery. Where is it? Really, I saw it come out, but it's interesting, some comical variation. Normally it comes out from 12 o'clock position, but you see here, coming out from about 6 o'clock position. Okay, so put the Doppler on again. So you can see here, the artery is now coming off the axillary artery in a slightly different location here. It's more posterior than its typical anterior location on top of the axillary artery. See there? This is on the posterior part, on top of the serratus anterior, and then I think it will swing across the vein before it punctures the, if it goes into the interpectoral plane. Now, this artery can be a very useful landmark when you're doing some other blocks like some of the pectoral nerve blocks, okay? Because all the pectoral plexus are actually formed at this juncture where the thoracoacromial artery emerges. And we will talk more about this in probably the last webinar when we talk about using regional anesthesia as a sole anesthetic for major breast cancer surgery. Okay, so this is it. Now let's do the sagittal scan. Now, when you do a sagittal scan, obviously the orientation marker is pointed towards the head, and to your right is caudal, okay? So now I place it, so this end is the cranial end. You can see here, I've aligned the probe directly in line with the axillary artery here. You can see the subclavius muscle very clearly there. And there you go, yeah, okay. And then if you just align the probe a little, you should be able to see the, I see the artery here. You can see the cephalic vein on top of it. Yeah. This is the vein that's going from right to left. You can see it's compressible. Compressible there. Okay. Of a different velocity. Okay, no. Right. So then you have the pec minor. You can see the pec major there, and the pec minor is just here. Okay, you can see here the pec minor. And why this is the upper border of the pec minor? I can say that this is a rib number 3. See here? Because the upper border, the pec minor is attached between rib 3 and rib 5. So you can see if I follow the pec minor here, rib 3, rib 4, and then rib 5 will be the one that is over there. Okay, so you see how the pec minor is spread over rib 3, rib 4, and rib 5. So if you're looking for counting the ribs, this can also be a very useful surrogate marker, looking for the attachment of the pec minor. Now I'm going to go a little bit more lateral, because you've now seen the vein here. The vein is medial. This is the vein. So this is actually useful. Also, it's been described as a transpectoral axillary vein cannulation. So you can perform a central venous cannulation at this level in some individuals where you can't place it in the neck or in the femoral area. This can become good, but be warned that the angle at which the needle enters the vein can be quite steep. So sometimes passing a guide wire is quite challenging. More importantly, the vein tends to get collapsed as soon as your needle touches the vein. So puncturing it, and you can see the pleura is not far away from the posterior wall. So this is never a first sight, but you can see that it can be useful. Okay, so if I go lateral now, you can see the artery, okay, and you can see the cephalic vein is right on top of it. The subclavius muscle is much better visualized. Between the subclavius muscle and the upper border of the pec minor is the clavipectoral fascia, okay? This is another fascial layer that you need to be familiar with. The cephalic vein is actually superficial to the clavipectoral fascia. And if we go a little bit more lateral, right, so if we now go, here we go. Now this is it. And if I just go a little bit lateral, you can see the long axis of all the chords of the brachial plexus there, see? Now, as I mentioned before, there are 2 chords, one on top of each other, which are just juxtaposition to the artery. So this is the lateral chord where the arrow is. The medial chord is just posterior to that, okay? If I go further lateral, you'll be only left with the posterior cord. So the posterior cord should be the one here. I think this is the posterior cord, which is now appearing hypo to anechoic here. This is the posterior cord. Then the two other cords are, here you go, here. These are the two cords. This is the lateral cord, and the one deep to that is the medial cord. Now, of course, you're not going to be doing your brachial plexus block like this, but I hope I can show you the Phrygian cap that I was talking about. So easy, son. Here we go. You can see here, the cords of the brachial plexus are arranged. Go a little bit more left. Here. So the lateral cord is the one right on top of the arrow there. Lateral cord. The posterior cord is posterior to that. Yeah, that's one. And the medial cord is just behind it there. So you can see the three cords are arranged in a, here we go. You can see lateral, that's the posterior, and the medial is just below that. No, to the right. Yeah, that's the medial cord over there. Yeah, that's the medial. Okay, so there are different ways. I think this is something you may keep in your armamentarium someday when you are unable to form a block. This can be a good window because this is the window that Kilka used to perform his Kilka blocks. So you can always advance the needle from a podocranial outer plane some way, as long as you can get it to that deep to the pec subclavius muscle, then you can produce a block which would be a medial infraclavicular brachial plexus block. Okay, so I think this is pretty much what I wanted to demonstrate to you, really, with respect to what we have discussed today. Okay, Roshini, are there any questions? Come closer.
Dr. Semmer is asking if you can do a demonstration on intercostobrachial nerve block.
Intercostobrachial nerve block. I can try. Okay. Give me the probe, please. Oh, you have to switch back. Okay. I think for the person who asked this question, it's important to remember that the intercostobrachial nerve that we often look for is in the axillary area. And as the group from Barcelona has, with Dr. Salis, Xavier Salablanche and them have demonstrated, you need to identify the conjoint tendon, because the intercostobrachial nerve lives on top of the conjoint tendon with one of the medial cutaneous branches of the nerve. So if we now scan the axilla like so, and as you are familiar with, when you look for the conjoint tendon, it's there we go. You can see the conjoint tendon. Okay. Okay. And then we are going to go look more medially here. So once you find the conjoint tendon, we look more medially, and now you can see the pulsations of the axillary artery are quite lateral here. Now the plane of imaging is where the arrow is, bring it down to the little bit down and to the right. Okay, so it is in this plane that the nerve is located. So if you want to do when we want to do an intercostobrachial nerve in this area, we usually sorry, my fault here. We usually identify the artery, the conjoint tendon, and then move it more lateral medially, the probe, and then try to find this plane on top of this latissimus dorsi and the conjoint tendon till you can deposit the local anesthetic in this plane. So we usually put the needle in this plane and inject the local anesthetic. In some individuals, after the injection, you can see some hypoechoic structures, or in some persons, you can also see them as they are. You scan them proximally and distally in a dynamic way. But they are small nerves, so not always very clearly visualized. Is this the highest resolution we are using, or put it on resolution? least 15 megahertz we can try. Reduce the depth. Reduce the depth, please. Okay, so let's see the tendon very clear. But as you see here, not very easy to define the nerve. But in clinical practice, if you deposit your local anesthetic in that plane superficial to that muscle and tendon, then you will usually take out this intercostobrachial nerve in most of these cases. So I would usually do it like so. Now, normally when you do an axillary block, this is the window that you are using. When you are, especially if you're looking for the posterior cord, the radial nerve, then you have to look for this where it enters distally and it leaves the nerves here. There you go. It's going into the radial groove. So just do it above that so that you don't miss the radial nerve. And then here you can look for this plane, which is on top of the conjoint tendon, but at the same time it is deep to the subcutaneous tissue and deep fascia. And so the needle can come quite close from here. You can see here, almost is subcutaneously really, and deposit, hydrodissect with saline and deposit the local anesthetic, 8 to 10 mils. You need a little bit of volume there, unless you can really see the nerve. But I usually use it as a volume block here. Okay, so hope that answers your question.
Okay. Dr. Smith, I would want to know if you can trace the supraclavicular nerve as well. Which
the supraclavicular nerves are, in my view, difficult to define. If you're looking at the supraclavicular nerves just below the clavicle, it's often not really definable. You can see here, if you just look, subcutaneous nerves. So even if you are looking to block them, I think trying to do it with ultrasound guidance, in my opinion, is trying to find the sky in the wrong places. Okay, so if you even go slightly above in the subcutaneous plane, it doesn't really show up very easily, even with high resolution, with a high frequency transducer, 15, 17 megahertz, you rarely will see it that clearly. So my advice is, when we do it for breast surgery in some of the cases where they have a larger upper flap, then you need to take out the middle and the medial branches of the supraclavicular nerves. And just a subcutaneous injection along the inferior border of the clavicle is usually adequate in most cases. If you're doing it for shoulder surgery, then you want to block the lateral one, that lateral branch. I hope that answers your question.
Thank you. From the chat box, Dr. Lee from Melbourne, asking a question for the costoclavicular block. Dr. Lee finds there's difficulty visualizing the needle in plane when there's a probe tilt in the costoclavicular block. So asking any tip for troubleshooting?
Yeah, I think it is. That's a very good question, Dr. Lee. You're up till quite late, so I'm going to give you a tip here. Now, when you look at the requirement of the tilt, a normal tendency. Do you have a pen or a pencil? Yeah. The normal tendency is to follow the plane of the skin. Okay, so you usually, because you're looking like so, and the needle will go like so. So it is a common mismatch that usually happens. And this can lead to partial or no visualization of the needle. My suggestion is, when you tilt it, place it closer to the proximal end of the probe. You see here, use the proximal end of the footprint as the way you want to insert your needle, rather than at the center where you normally want. So if you place it closer to the upper end of the probe, then you will enter the plane very quickly. And if you do not visualize the needle, don't try and withdraw it and reinsert it. Find out where the needle is. I think common sense would say you should move rather than the needle, because this is going to cause pain to the patient. So once you do not see the needle, analyze where your needle is relative to the plane of imaging. If you find that the needle is too cephalad to your plane of imaging, then all you need to do is just withdraw and just redirect it a touch in the caudal direction, and vice versa. So these are two tips that you may find quite useful when you are performing a costoclavicular block. Try not to insert it close to the center of the probe. Insert it more closer to the upper end of the transducer. And two is, once you insert it, it is paramount to locate the tip. So move the probe, slide the probe up and down, and then find out where your probe is relative to the needle, and then readjust accordingly. Okay?
Okay, thank you. Dr. Mathakuma is asking what's the difference between a Kolkata block and a costoclavicular block. I'm also not very familiar with Kolkata block. I'm not sure if, Prof, you know anything about
No,
this.
I don't know what a Kolkata block is. Maybe it is from Calcutta. But Kilka block, not Kolkata block. Okay, I never heard of a Kolkata block from West Bengal. It is a Kilka block. Kilka block is a block that used to be done in the early 90s, where you did a proximal infraclavicular brachial plexus block by inserting a nerve stimulating needle to identify the midpoint of the clavicle and insert the needle perpendicular to all planes. You insert it till you see the flexion of the elbow. Now, because as I showed you in the anatomy in this area, in the Phrygian cap, the lateral cord is the most superficial of them. So you will find the lateral cord response. But also at the same token with this Kilka, K-I-L-K-A block, it's a German anesthesiologist by name. If you just injected a local anesthetic based on just a flexion, musculocutaneous, or the biceps response, then your block is going to be very poor. So in those days, it was often recommended that once you get the lateral response, you advance the needle further till you get a medial response. So today we can say that in many of those cases, you actually went through the lateral cord, or on the side of the lateral cord, somehow you went and got the medial cord response, flexion of the finger, and so on and so forth. So that is the difference with it is a Kilka block is not ultrasound guided. It is usually nerve stimulator guided, and the motor response you're looking for is the lateral cord followed by the medial cord. And if you inject there, then you'll get a very good, dense, rapid onset of sensory motor blockade. With the costoclavicular brachial plexus block, we are doing an ultrasound guided. We are coming from a lateral to medial direction. We are placing the needle at the center of the nerve cluster, and you're using a relatively small volume, 20-25 mils of local anesthetic to produce surgical anesthesia of the upper extremity, effective for surgery, maybe below the mid-arm to the hand. Okay, hope that answers your question.
Okay, we've got one last question from Dr. Eric Defroux from France, which is quite interesting. Can an intercostal block at the second rib during an infraclavicular block be spread to the intercostobrachial nerve?
That's a very good question, Eric. Wise men always think wisely. Yes, I think it is possible because the intercostobrachial nerve is not far away from that area. So it is with the same token, I always think that when you do an a costoclavicular brachial plexus block, because the costoclavicular space, if you go more lateral on top of the serratus anterior muscle, that's where these nerves are located, your long thoracic nerve. So I think the long thoracic nerve is probably one of the collateral damages of, I'm not saying collateral damage, it's a collateral block of a costoclavicular block. Now, nobody has really evaluated it, but I think it may happen that the long thoracic nerve is also affected. Now, if you look at the intercostobrachial nerve that comes out from T2, the T2 nerve, if you look at the second rib where we are performing the block, so further laterally, the intercostobrachial nerve takes off and before it reaches the axilla. So I think a large volume of local anesthetic in that area may produce intercostobrachial nerve. Yeah, for to block that nerve. This is all I can say at this moment.
Okay, thank you. I think that's pretty much all the questions in the Q&A box.
Okay, thank you, everybody. I'd like to take this opportunity first to thank Rossini. I hope you learned as much as I did during this session. Thank you for putting it all together. Also, I'd like to take this opportunity to thank folks from VISonic, Candice, what's the other one? Vicky and Christopher, is it? They are being very active in marketing and supporting. So thank you for supporting us with your equipment and all your support. Daniel, for you coming out and helping us out during this live demonstration. And I thank you all for your confidence and in us and spending your Saturday and a weekend learning all these funny things that we do in the operating room. But at the end of the day, you've learned a few secrets. Don't give it away so easily because you spend the whole afternoon or morning, or in some cases, like somebody from South America said, it's 5 o'clock. So that was a good morning for you to have a warm cup of tea or coffee, put your feet up and listen to us in your large television. So keep doing that. We have a few more, and we have a few more secrets, particularly the next one is how do I say this in a very simple way? Is a debate with a lot of emotion that's going to come up. So I would advise who are interested in the thoracic nerve blocks to be there, because all of the high-powered people in this area will be there, and they will be thrashing it out, say what is good, what is bad, and what is not so good. So with these few words, I would like to now sign out and see you again next Saturday in 2 weeks' time. Take care and bye-bye for now.
Thank you.